Welcome to the official launch of Dermapen for Ireland. I'm Dr. Andrew Christie Sept. I'm the clinical director and global medical trainer for Dermapen World. The accent is kind of Australian, but I'm also living in France for a long time now. But I specialize in microneedling. This will be my 23rd year for this topic. So all of this knowledge is a culmination in conjunction with all things Dermapen World, including Dermapen 4, DpD Dermaceuticals, and also the new MG collection, which joins together as the ultimate synergy of solutions, taking microneedling above and beyond just the traditional parameters of collagen induction therapy, but also just a procedure for scar revision. When I look at the value of any procedures that you offer in clinic, its value is not dictated by you. Its value is actually dictated by the modern patient. We've seen so many changes with the modern patient over the last 20 years with their wants, their desires, their needs, but also their expectations. What's changed? 20 years ago, if you were to ask someone, what do you want from us? What do you want from an aesthetic practitioner? They would have said, I want you to take 20 years off. I want to look 20 years younger. We know that this is not possible. However, now there's been a very, very big change, particularly with the growth and surge of what we call regenerative medicine, that the modern patient is a lot more reasonable. So they will talk about, I want to look as best as what I can. I want my skin to be healthy. I want my skin to be good quality. And this change works in flawlessly as a synergistic solution with your Dermapen 4 and of course with your DpD Dermaceuticals. With the modern patient, I guess to quote Jim Morrison from The Doors, we want the world and we want it now. So they're looking for fast, affordable procedures which don't hurt, which don't have extensive downtime, but the modern patient also is extremely bored. They spend a lot of time on social media and they want what's new. What they also want is variety within their treatments. So looking at our considerations, from a Dermapen 4 perspective, the treatment itself can be performed in as little as 3 to 5 minutes for a face. So you have a very fast, effective treatment. That equals profitability for the practitioner, but likewise, that also equals a time-efficient procedure for the patient that can be performed in as little as a coffee break, a lunch break, or something that they can fit in between appointments. For a standard Dermapen 4 procedure, the patient will experience 36 to 48 hours of a mild to moderate sunburn. So you should never see any bruising. You should never see any grazing. There should never be any track marks, nor any flaking of the skin. So with this, we are looking at one of the fastest turnarounds and recoveries for an autologous or regenerative medicine procedure. So we have something also that is affordable. So the consumable for you as the practitioner, of course, is your needle cartridge. It's going to be your sterile consumables that you perform as part of the treatment. But today, as we develop in with combination therapies and new opportunities, you're going to notice that you can equal the same level of profitability as what a medical practitioner can with botulinum toxin, with fillers, but you can also equal above and beyond the same level of profitability for any procedure that you're currently offering. So this means for the modern patient, it's quick, it's fast, it's affordable. There's no extensive downtime, so there's no flaking, there's no shedding. It's not 2 weeks of having to hide away. The modern patient is very bored, and it takes just a very quick look on social media to see that people have no allegiance to a treatment, very little allegiance or loyalty to a product because they want everything that's new. When I look demographically from statistic perspective, there's 2 types of patients that you're going to come across. On one hand, you have the naturalist. The naturalist, in want of better terminology, is looking for procedures that are chemical-free, Dermapen. They're looking for procedures that don't have injectables, Dermapen. procedures that don't require extensive downtime or are overly medical in their approach with intense pain and intense trauma and discomfort, Dermapen. What we're relying on is called autologous regeneration. Quite simply, the largest growth area in all of aesthetic medicine globally are regenerative procedures. This describes a group of procedures which work with your body's own process of healing, repair, regeneration, renewal. So with this, there's two areas I want to have a look at. Number one, this is a machine. If you don't put the right fuel into your machine, you cannot expect your machine to run efficiently. So regenerative medicine is very reliant on diet. But also for regenerative medicine, this suits the naturalist patient because it's their body working with their own mechanisms and no chemical or surgical intervention, if you know with those loose terms. On the other hand, you're also going to catch up with the high-tech patient. They want anything and everything that modern aesthetics has on offer. So this is going to include surgery. This is going to include injectables. This is going to include anything and everything that they can possibly access out there. Dermapen will work in for infusion of active substances, mesotherapy. Dermapen will work in flawlessly with PRP. Dermapen will work in flawlessly for pre- and post-operative care for surgical procedures. It can be used for nanofat, for microfat. Likewise, we can also see the infusion of steroids, antimitotic drug combination therapies, and even use with Dermapen with botulinum toxin, which is an innovative treatment called Mesotox. So what we see out of this is not just suitability for the two styles of patient that you'll typically come across, but we see intense versatility right across these markets. The microneedling story has continued for some 2,000 years. So if we look right back to traditional Chinese medicine with the practice of acupuncture, we know the insertion of a needle can affect the flow of qi or affect the flow of energy through the body's meridians. Whether you follow that or whether you don't follow that, we still see that there is a reaction to that needle from the body. This then led us to precursors for microneedling, including subcision, the microneedling stamp, the microneedling roller in the 1990s. The philosophy is exceptionally simple, and this is what you will want to describe to your patients. Think back to when you were a child. You're riding a bike, you fall off, you graze your knee. When you graze your knee, on goes a sticking plaster. That remains in place for about 3 to 4 days. After that time period, you remove the sticking plaster. The skin which was traumatized, which was damaged, you'll now notice is whiter, pinker, softer, smoother, better texture, better tone, and even better quality than what the surrounding tissue is. So for very basic backyard science, we understand that if human skin undergoes a process of micro-trauma, then human skin has the capability to reset, reheal, rejuvenate, and to regenerate itself to an even better condition than what it was before. This is what we facilitate with microneedling, but this is what we facilitate in a controlled but resolved way with Dermapen 4 technology. When I have a look at the two most common procedures in aesthetics, you're going to understand the value as to why you need a Dermapen 4 in your practice and in your clinic. This is a non-negotiable. The number one procedure that we see in aesthetic market globally is microdermabrasion, which is very closely followed by superficial chemical peels. Very, very quickly, I failed art school absolutely dismally, but this is just my interpretation of the skin. Absolutely nothing is to scale here. Your microdermabrasion is working on stratum corneum of the epidermis, basal, spinosum, granulosum, receding corneum. Unless you are bleeding, your microdermabrasion is not exceeding stratum corneum in this case. So, number one reason why a patient is going to come and see you in clinic worldwide is for anti-aging. Anti-aging, what is your pathophysiology? What cell has gone wrong? We're looking at a fibroblast. Fibroblast is what produces collagen. If your fibroblast is sitting in papillary and reticular dermis, and your treatment is targeting stratum corneum on corneocytes, there is absolutely no connectivity here. It is absolutely physically impossible for you to reverse, prevent, repair, treat, target, manage what's happening down here in dermis. So what about hyperpigmentation then? Many practitioners will say that I can correct, I can rebalance with a superficial chemical peel or microdermabrasion with our modality for treatment of hyperpigmentation. Again, pathophysiology. What cell has gone wrong? It's a melanocyte here, which resides in basal epidermis. The melanocyte with its dendrite arms is going to hand over a pigment capsule, which occurs into the keratinocyte and then occurs in spinosum. If your device is working on stratum corneum, but your problem is a cell in basal, and your problem is a chemical reaction that occurs in spinosum, again, there is no direct cell interaction. This is a huge problem. So then the more sophisticated patient will say to you, this is too aesthetic, this is too beauty for me. What I want is the hardcore procedures. So the number one procedure for the medical market globally is botulinum toxin. Again, I want to show you limitations. I've been moving my left hand for a very long period of time. With this, if I put in 48 units of botulinum toxin, wait desired time, you'll now notice that I can no longer contract the muscles. Perfect. Do I still have lines and wrinkles in my hand? Absolutely. So with this, what you're doing is preventing a muscular contraction, but you can't reverse the contractions that have been performed in the past. Likewise, also, when you have an intramuscular injection down here, it has no effect on skin texture, quality, tone, functionality, or integrity that's sitting further up. So what creates a very unnatural look for so many patients is bad quality skin, which doesn't move. On the other hand, we take into account the filler market. With the filler market, you can inject as much hyaluronic acid or as much revolumizing agents as you want subcutaneously or periosteum, so above the bone here. But again, this creates volume. But again, it still has no effect on skin texture, tone, quality, or integrity that sits above. That is why you need, as a core basis, Dermapen and your automated microneedling to now physically treat texture, tone, quality, integrity, and the health of the overlying tissue. The problem with this microneedling story is that so many practitioners are focused on 30-year-old technology. As an example, if you go onto an internet search engine and type in microneedling, dermal rolling, skin needling, these are typically the types of images that you're going to be presented with. These are indicative of 30-year-old technology. From the patient perspective, when they see these types of images, they will believe that this is an exceptionally brutal procedure. When they see that level of blood, they associate it with pain. When they see that level of blood, they associate it with intense downtime. It's not like that for 2021. It's not like that for an updated, enlightened Dermapen 4 practitioner. So the oscillation or the speed and the automation of the device will dissipate nerve receptors, which means you can treat even without use of a topical local anesthetic. You feel vibration, you don't feel pain. Likewise, also, you don't see bruising. You don't see scabbing, there's no grazing, there's no track marks. It's 36 to 48 hours of a mild to a moderate sunburn. Likewise, also with this, more blood, more trauma does not equal a better treatment. So you're going to have these challenges where you see practitioners who are desperate for likes and desperate for attention, now posting these types of images with microneedling back onto social media to try and get attention. This is not a better treatment. To explain, from the medical perspective, we believed 30 years ago, we believed in the 1990s that the more blood, the more trauma you created, then the better the treatment would be. However, the pioneer of the microneedling stamp and roller, Fernandez, a plastic surgeon from Cape Town in South Africa, reassessed a lot of his earlier work in 2008. This clinical was performed with his German counterpart, Aust. What they determined is you achieve the same level of collagen activation, synthesis, regeneration, and also stimulation, irrelevant whether your needles are 3 millimeters in depth or whether your needles are 1 millimeter in depth. What also came out that year in 2008 was a study by the lesser famous Joe Greco, who produced a clinical that stated that the new collagen you perform, the new collagen that is created, begins to form at around about 0.6 millimeters into the skin and then starts working its way down. So just because you can go to 3 millimeters, just because you can create this effect, does not mean you're creating a better treatment. More pain, more trauma does not equal a happy modern patient. The other challenge of the 30-year-old microneedling story is that it's only associated with collagen induction therapy. This is the other very common name for microneedling. Collagen induction therapy means scar revision, it means age management, but also striae treatments, so stretch marks. That's 3 things. That's an issue because statistically, number 2, the reason why a patient is going to come and see you in clinic globally is going to be for hyperpigmentation. Where's the value of your microneedling? When we look for the Irish market specifically, we understand that acne is on the increase, but we also understand that this is a market particularly affected by telangiectasia and rosacea as well. Where's the value of needling? So looking at new methods, new updates with Dermapen 4 technology, we now remove the collagen induction therapy restrictions to understand that you can treat above and beyond, say, 70 standard indications that you will see on a daily basis. But this story also grows significantly. The strangest things that I have seen Dermapen use for. Alopecia X. Whilst many of us know that Dermapen is successful for alopecia, alopecia X does not affect humans. It affects Pomeranian dogs. And so a veterinarian surgeon has developed new techniques with Dermapen 4 for treatment of alopecia X on Pomeranian dogs, which is an autoimmune condition, to now facilitate stabilized new hair growth. A team of surgeons in Zagreb in Croatia use Dermapen 4 for direct treatment of the uvula at the back of the throat. The treatment takes about 7 seconds. A mild muscle relaxant such as Dermapen prior to treatment to slow the breathing down, and it can reduce the effects of snoring up to 50% in as little as 2 treatments. We also see success in the dentistry market for receding gums and also for dry mouth syndrome. Your collagen or your fibroblast, which produces that, also produces glycoproteins, which maintains moisture in the mucosa. We also see success in the podiatry market as part of combination therapies for mosaic warts. Moving into gynecology and urology, particularly for vaginal, penile, and anal regeneration and rejuvenation. This is one of the newest growing areas, particularly as consumers are exposed to more pornography and because consumers are exposed to more bodies on social media that they want to look a certain way. But we also see success in the trichology or hair loss market. Moving into very traditional hardcore dermatology, success for burn contracture scars, success for alopecia areata, success for vitiligo, but of course we also see our success in the aesthetic market. So the microneedling story with Dermapen 4 has developed and changed the market so dramatically. Why you want this is not just because you have so much versatility when it comes to indications, not just because you also have efficacy that suits the modern patient, fast, comfortable, affordable, versatile. Not just also that you can appease your high-tech, but also your more basic consumer who's coming in. The other reason why you want this is safety. There is absolutely no heat in a Dermapen 4 device, which means you can treat 100% of Fitzpatrick skin types and 100% of ethnicities coming into your practice with no risk of post-inflammatory hyperpigmentation. Likewise, also, by contrast to the traditional microneedling roller, the needles do penetrate at a 90-degree angle, but 75% of your revolution are the needles cutting and arcing through the skin. That equals ablation and slicing of the tissue. The reason why is because as the barrel turns, the needles need to be significantly larger in size so that they don't snap within the skin. So when you create ablation, when you create major trauma within the skin, that equals an activation of profibrotic growth factors. So for patients with a risk of keloids, with a risk of hypertrophic scarring, they're not suitable for these types of procedures. But for nearly 100% of patients coming through your clinic door, they will be suitable for Dermapen 4. And as such, what we now promote and what we now deliver is the ultimate of versatility, the ultimate of affordability, profitability, ingenuity, safety, predictability, and most importantly, reliability. This is the benefits, and this is the success of Dermapen 4. With thousands upon thousands of hours of research and development, Dermapen 4 is the biggest launch in the entire history of microneedling. The Dermapen brand was established in Sydney, Australia in 2010 with the release of the E-Pen, or what's now known as Dermapen 1. This was the first automated microneedling device ever created. So Dermapen is a brand name that is owned by Dermapen World. There is only one Dermapen, and that is ours. If it doesn't look like this, you do not have a Dermapen, you have a microneedling device. In 2012, the Dermapen 2 was launched with some slight changes and updates. It rapidly became the most used microneedling device across the world market. Its popularity hit such a peak that it also became the most copied automated microneedling device in the market still to this day. Dermapen 3 was launched in 2014 with further updates and also further design elements, and Dermapen 4 was finally launched in 2018. My last count, as I looked online for how many countries there are in the world, I counted that there's presence with Dermapen 4 in 88 countries. There's 55 formal distributors, worldwide, and we understand that this is the most used automated microneedling device right across the medical market globally. So why do you want a Dermapen 4? The Dermapen 4 technology features many patents and many updates that are exclusive to Dermapen World. Firstly, this is the world's only fully digitalized automated microneedling device. So there is no platform, which means there's no risk of cross-contamination as you're touching a platform, touching the device, touching skin. So with this, it means that your single hand can then operate the needle depth, but then also the speed at the side here with one hand. So the minimum needle depth is 0.2 of a millimeter. This allows for smooth efficacy that will treat the eyelids, the full periorbital area, but even for intimate rejuvenation. So there is no way that you cannot use a Dermapen 4. The device goes up to a top of 3 millimeters, and this again is a world first. In order to have that level of needle depth, you need to have the power or the motor to drive those needles, because if there's not the power, then the needles will simply rip and tear through the skin. At 3 millimeters, it's called ST, which is scar treatment setting. With the device, you have 5 speeds. So speed 1 is working at 66 revolutions per second. Speed 2 is 90 revolutions per second. Speed 3 is 105. And speed 4 is an unparalleled 120 revolutions per second into the skin. If you automatically set the device to the scar treatment setting, you'll hear that it reduces the speed down. This self-calibrates, so you cannot change it, but it reduces the speed down to just 60 revolutions per second. This now opens up new areas and innovations for gliding technique, but what I also refer to as imprint technique. And we will explore this in a few slides' time, understanding the difference between a generalized rejuvenation, but then when required, localized precision, particularly for scar work and particularly for atrophic writers or deep aging within the skin. Otherwise, the key advantage that we have is called advanced oscillating vertical needle technology, which means that the needles enter cleanly and exit the skin cleanly. There's no ripping, there's no tearing of the skin. So as such, the needles are a 33 gauge, which makes them significantly smaller in size by comparison to a roller, which means that your patient never leaves the clinic oozing or bleeding, which means we achieve full reepithelialization by the conclusion of the procedure. This removes your risk of cross-infection. This also means that you're not having to rely on antibiotic creams and also having to rely on any systemic antibiotics. The design of the device really features in how the motor creates comfort. So on a flat surface, which I can't guarantee that the table is here, you'll see that the device will stand in perfect position. Let's try here. So on a flat surface with this, you'll notice by contrast to, for example, a laser handpiece, that the weight is evenly distributed. So for the practitioner, it's not a heavy device to hold, but then also for the patient, as it makes contact with the skin, it's not a thump and drag across the skin. So this perfect weighting means that it's light, it's easy to hold, it's easy to function, and you will not weary from having to hold the device within your hand with multiple procedures and multiple treatments. Within the first week of the launch of Dermapen 4, it won 3 Good Design Awards. Number 1 was from Australia, number 2 from Germany, and number 3 from South Korea. A key element that contributed to our success in winning the Good Design Award is the needle cartridge. The needle cartridge is 16 33 gauge needles. With this, we then offer a variety of speed options between 66 revolutions per second up to 120, or if you go into your scar treatment setting, it will automatically self-calibrate down to 60 revolutions per second. So a needle range 0.2 right up to 3 millimeters, and this can be changed at any point at any time throughout the procedure. There's 52 individual components that make up this single needle cartridge. This is the reason why it's going to be more expensive by comparison to a cheaper device. Let's explore the features. Firstly, this is the only direct drive automated microneedling device on the international market. To explain direct drive, the needle cartridges for every other device are a spring load. So I want you to imagine a child jumping on a trampoline. I want you to imagine springs. Over time, those springs are going to lose their elasticity. They're going to stretch. That's a problem during a procedure when you put pressure via a motor. What this means is that you create needle fatigue. As the springs begin to lose their elasticity, that slows the device down, which means track marks, which means discomfort for the patient, and then complications leading into post-inflammatory hyperpigmentation. For the Dermapen 4 device, you will notice that there is a hook up the top of the needle cartridge here. And what this hook does is physically locks into the Dermapen 4 pen, which now means that similarly to the motor of a car, it's pistons within the device that physically drives the needles. It's not a spring load. So because the control is coming through pistons, that means that you will be able to treat the surface area of around about 3 to 4 A4 pieces of paper in a single setting. So you can treat large treatment areas, an entire front, an entire back, thighs, buttocks, inner thighs. So you have large variety and durability with the needle cartridge. Likewise also, it means not only does it remove the risk of needle fatigue, but it also removes the risk of needle bending. So durability becomes significant. Furthermore, at the top of the needle cartridge is a very small radio frequency identification chip. This is read by the pen. What this does is ensures that, number one, if I remove my needle cartridge, you'll notice that the pen recognizes and it begins flashing up a needle cartridge. So this tells me that this is not in position correctly or it's not in position at all. Your interactive digital screen will tell you everything you need to know, from battery status to sinking status to needle status to depth to speed, so on and so forth. When I insert the needle cartridge, it's read by the radio frequency identification chip. So there's absolutely no flashing now. But whichever speed I dial up is guaranteed the speed that is going into the skin. At 1 millimeter, that is precisely 1 millimeter. There is absolutely no variation. So it ensures that the depth you dial up is the depth that goes in. What about if I don't put the needle cartridge in fully correctly? You'll notice that it's acknowledged that the needle cartridge has been inserted, but it will self-calibrate with the radio frequency identification chip, even if I don't insert it correctly, to ensure that what you see here is what physically goes into the skin. The design of needle cartridge is paramount for comfort. It's paramount for speed. It's paramount for efficacy. This is why we have such a sophisticated design element. Furthermore, there are scalloped edges, which means that these scalloped edges allow for breathing. The scalloped edges ensure that you can treat over bonier contours, particularly around the cheeks, around the nose, and it will create a smooth, easy glide. Air goes through these, which means that we don't create a vacuum. When there's no vacuum, there's no extended contact, which means a smooth, effortless, and easy glide over any type of contour, whether that is hard or whether that's a softer contour. Furthermore, there are 2 breathing channels in the needle cartridge. This again prevents any vacuum. No vacuum removes your risk of bruising, minimizes risk of petechiae, but also removes heavy contact so that we can allow for a smooth, easy glide and a smooth administration through these design elements of speed, guaranteed depth with the radio frequency identification chip, the breathing channels, but also with the scalloped edges. The design of this continues on with what we refer to as an isogeometric formulae. This is the design of the needle cartridge, but the relationship between each of the needles. You can see that microneedling is not so simple of just putting needles together and then dragging them across someone's skin. The spacing and the relationship of these is important and will determine whether there's resistance, whether there's drag, which creates track marks, or pulling, which then leads into scratching of the skin and then leads into all the complications, including post-inflammatory hyperpigmentation. So with this very, very specific design here, it ensures a smooth, easy glide, irrelevant of whether you're working on face, body, or scalp. We now have a new design element, which is a solar light stone, which features as the tip of the needle cartridge. There are very many ways that you can administer a Dermapen procedure. And so we see from the hardcore medical market, which will allocate 7 to 10 minutes per patient, treat the patient, send the patient home. But then we also see Dermapen feature heavily within the aesthetic market who want to create a more holistic approach to their treatment, to extend that to 1 hour, to extend that to 1.5 hours. The solar light stone here can be used to aid lymphatic drainage. It can be used to aid infusion prior to treatments. We produce a CBD range, which will serve as an appropriate analgesic. I'll explain the complications of topical local anesthetic and why it potentially should be avoided during treatment. But likewise, also with this solar light stone, it can be used to create comfort. So dial the device up to the smallest, which is 0.25. You want your slowest speed, and you can use this to create massage even over a post-operative mask for lymphatic drainage, and vibrational therapy will dissipate nerve receptors and aid further comfort. So there's a whole host of features that will enable a very holistic spa-like approach, but also still be suitable for a more hardcore medical approach. So the needle cartridge is absolute pinpoint precision. At top speed, it is 120 revolutions per second, and with 16 33 gauge needles, that now delivers an unprecedented 1,920 puncture channels per second into the skin. From a sales perspective, practitioners will generally assess the value of a microneedling device based on the number of needles or based on the speed. The reason why is if you have a device with 20, 30 needles, and we tried creating a device like that, but it would be the size of a 2-liter soft drink bottle. It's too big, it's not practical for that. If you have a device with many, many needles, you need to have the power to be able to drive and operate that. And if it's not powerful enough, then the needles will drag and rip through the skin. If you have a device that's very, very powerful, but there's only very, very few needles, if you think of the needles of a tattoo gun, the problem is that you have too much concentration, which creates ripping and tearing the skin, particularly for large surface areas. So the harmonious relationship for a Dermapen 4 that we've explored every option for this relationship is 16 33 gauge needles and 120 revolutions per second at fastest speed, which is now the fastest automated microneedling device in history, with the highest number of fractional rejuvenating puncture channels per second. The epidermis remains intact as we deliver 1,920 puncture channels per second. As microneedling now becomes more common on the market, as with other procedures, including PRP, procedures which draw blood, and other procedures, including nano or microfat, we are more aware of hygiene and we are more aware of being able to deliver safe and effective procedures. And I think particularly over the last year and a half, as we become more aware with hand hygiene, with masks, we understand just how easy cross-contamination can become. As such, we have a world first with an anti-contamination management system. This is firstly highlighted by 4 silicon membranes which exist within the needle cartridge. They look like a concertina, as we see with the previous video. So with this concertina here, as that moves up and down, that physically prevents any procedural fluid, whether that is blood, whether that's serum, whether that is mesotherapy, whatever that's going to be, from physically getting up and into the needle cartridge. This is also facilitated through the solid edges, which allows the fluid to move through, but then also the breathing channels, which will prevent any fluid buildup in the needle cartridge. That also guarantees and ensures that you cannot get any procedural fluid into the pen itself. So with this component here, by ensuring that you do not have any cross-contamination, guarantees and ensures that you have the ultimate of safety, efficacy for every patient, for every procedure, every time. In fact, what we also produce is a sterile latex sheath. It looks a lot like a condom, which will cover the entire device. And we also promote, as part of our procedures, using sterile basic dressing kits, sterile gloves, sterile consumables, but also sterile mesotherapy or facilitating glides, now ensures that you have the safest procedures in the market, the safest and the strictest protocols that are available within the market. So all of this now allows for safety for the practitioner, but also safety, reliability, and most importantly, trust from the inventors of automated microneedling for the modern patient. As a world first, the Dermapen 4 offers Bluetooth connectivity. This is important because I'm not coming back next year to launch Dermapen 5. I'm not coming back in 2 years' time to launch Dermapen 6. Dermapen 4 is it. Why? All you simply need to do is go onto Dermapen World application, which you'll find in the Android or iTunes store. When you first get your device, you're going to register your clinic. Don't register you, register the clinic. The Dermapen World application allows for optimization of internet search engines, optimization of all major social media, and optimization of all Dermapen World internet web appearances. This creates free advertising for you. So no matter where I am in Ireland, I can be connected to my closest authorized treatment provider, or ATP. We only award this status for Dermapen 4 users and educated Dermapen 4 users. So with this, it now highlights those practices and clinics which are using the original trusted Australian Dermapen. By signing into this account, and you will have the same password and a clinic email address that you will give to all of your colleagues, what this now allows for you to do is to register the pen, but also sync your pen. To sync your pen, what this allows is the updating of firmware technology. So for the same reason that I need to update my applications on my phone, the same reason that you also need to update your applications on your laptop, which then gets it working more effectively, more efficiently, it's the same thing that you can also do with your Dermapen 4. And so this just requires a small syncing process. The pen will tell you when syncing is required. It will give you fair warning. If you don't have time to sync the device right now, you simply wait 26 seconds and then you are able to work with the pen. But likewise, the pen will also count you down when you have 30 days before it will force a sync. And this ensures that you always have the most up-to-date education and the most up-to-date firmware. So the role of the app links you into the full realm of Dermapen World. And of course, also with Dermapen Island, this also links you in with your world of education, training, business support, and all aspects involving the Dermapen world. The device runs on a single turbo-cut lithium battery. This runs for exactly 90 minutes, not 89, not 91, but exactly 90 minutes at full 100% power. Of course, you have a battery charger. I suggest you keep one battery in the pen and the other battery in the charger. This means that you will never be out of power. With this process though, if you forget, you do also have the capability for mains power. It is a 4-meter cord. The advantage is that for the first time, this turbo-cut lithium battery is exclusive to Dermapen. So it will not operate your television remote control, and neither will your television remote control battery operate your Dermapen. But it means that you never compromise the physical power. So it is always 100%. If you turn your Dermapen on and the light flashes red, this means you're going to have a battery problem. Replace before your treatment. If the battery starts flashing because you ignored the red, that's telling you work quick because your battery is about to run out. So everything you need to know becomes interactive from your Dermapen interactive digitalized screen. So the syncing now enables new technology, but now also enables an unprecedented 7-year warranty. We've never seen this before with capital equipment anywhere in aesthetics. So once you register, once you sync, there is a 7-year warranty for the device. So this now guarantees and secures that you have the most up-to-date technology in 2 years' time, 3 years' time, 5 years' time, and of course, 7 years' time. I now want to move into a new direction and a new area focusing on value of Dermapen, but now exploring above and beyond the 30-year-old microneedling technology. For me, the 3 biggest questions of microneedling that I receive daily, which can be in the form of instant messages, emails, WhatsApp, text messages, phone calls, anywhere up to 400 a day, the number 1 question I get is, which depth, which depth, which depth, which depth, which depth, which depth? Number 2 is, what exactly can I treat? I know microneedling is great for scars, but can I use it for rosacea? Can I use it for pigmentation? And number 3, and this is a more controversial area, is how frequently can I treat with my Dermapen 4? The microneedling roller has created many issues for me because it's dictated to patients that your success is about a numerical depth or mathematics. It's not. Who said that all anti-aging procedures must be 1.5 millimeters? Who said that all pigmentation treatments must be 0.5? And who said that all scar treatments must be 3 millimeters? Because it doesn't work. Your skin density or reactivity changes from region to region to region to region, but also day to day. One area, which I'm sure you're familiar with, I call the Monday morning phenomenon. If your patient has been out in the sun drinking all Sunday afternoon alcohol, they're going to bleed significantly easier on Monday morning by comparison than if you were to see them on their lunch break on a Wednesday afternoon. So the challenges is that rollers and stamps do not deliver the versatility when it comes to being able to change and customize depth based on a reaction, but based on the patient's individual skin texture, skin thickness, its density, but also the areas that you're physically treating. There's absolutely no surprise that there are 3 layers of skin. So we are going to start off with the hypodermis, otherwise known as subcutaneous. We then have the dermis. I'm going to draw this up, but this is one of the least spoken parts of the skin, which is the epidermal junction. And then, of course, we have the epidermis. This is not on the scale. I want to show that there is a very big difference whether your needles are working here, here, or here. Your biological response will be different. Your chemical cascades that you activate will be different. And the key cell groups that you are targeting will also be different. In addition to our layers, we have sublayers within the layers. And again, that will determine a different composition of cells, a different chemical cascade, and a different response. There's no sublayers in the hypodermis. There's 2 in the dermis, papillary at the top, reticular at the bottom. There's 5 sublayers in the epidermis. Basal, spinosum, granulosum, lucidum, concentrated around the palms and soles, and then corneum up the top. So what I want to show here is not only do you have a difference whether you are epidermis or dermis, but you also have a different biological response whether you are targeting granulosum or whether you're targeting basal. With this process, the 30-year-old microneedling pioneers still to this day say hit down to the hypodermis every treatment, every time, and you will have the most advantageous response. No. And the reason why this doesn't work, it's all got to do with cell composition. The most dominant cell found in the hypodermis is an adipocyte or fat cell. The adipocyte accounts for around about some 87% of cell composition within this area. Fat cells don't make collagen, they don't make elastin, they don't make glycosaminoglycans, they also don't make glycoproteins. If you want collagen induction therapy, wrong cell. So if you want a true collagen induction therapy, then you want to target a fibroblast or a collagen reducing cell. But if my fat cell is 87%, even if you're not good at mathematics, you can tell there's not going to be a lot of fibroblast potential down here in the hypodermis. So as such, the fibroblast only accounts for around about 5 to 7% composition. That's not a lot of potential, despite the fact that we've always been told, go deep, go aggressive, go traumatically. Wrong layer, wrong cell, wrong response for most indications. Moving on up to the dermis. The fibroblast in this case accounts for some 85% of cell composition. So you can see that from a true collagen induction therapy perspective, don't target your needles here, don't target your needles here where there's no fibroblast. This is your key area that you need to be directly treating and targeting. So remember our example with microdermabrasion up here. Remember our example with muscle relaxant injections down here with your Dermapen. You can target any area you want. You just need to make sure you've got the right relationship with the right cell. With the fibroblast, it's responsible for production of 4 things. That includes collagen. That also includes elastin, glycosaminoglycan, which is chains of polymucosaccharide. That's my fancy way of saying hyaluronic acid. And then you also have glycoproteins. Glycoproteins are important because that's what holds the physical moisture within the mucosa into the inside of your mouth. From the fibroblast, a couple of considerations that I want to move into with the regenerative medicine story. We understand that this is a machine. The better the fuel, the better the quality you put into this machine, then the better the response is going to be when it comes to the machine's working, the machine's action for this. I just want to deviate for one moment to talk about the role of fibroblasts and particularly the role of collagen. Collagen is the most abundant protein found in the human body. There's some 27 known forms, and about 7 of these are associated with the skin. Not only do you find it in the skin, but you also find it in muscles, ligaments, tendons, and bones. Collagen production begins to deplete at a rate of around about 1.7-ish% a year from the age of 20 onwards. So we understand that the younger a patient, the more collagen potential and abundance there is, and for an older patient, then the lower your potential is going to be. I'm going to tie this in with treatment frequency later on. What you feed your machine plays a very key role for how you affect this collagen. It's not unusual that you perform a regenerative procedure, Dermapen, PRP, nanofat on a patient, and the patient's expectations are not met. Where's the problem? The practitioner, the device, or the patient? It's the patient. When I have a look at the role of collagen, you can beg, you can plead, you can bribe a fibroblast to produce collagen. It doesn't mean it's going to happen. There's a slight mathematical equation here. I suggest you take photos because I'm going to need to wipe this off later. But systemic plus also topical in this case, because topical products haven't always played such a key role in regenerative medicine. But vitamin C plus a fibroblast equals collagen. This is an issue if you smoke. One cigarette depletes your entire recommended daily intake of vitamin C in one shot. If you have no vitamin C, then your fibroblasts cannot produce collagen. So you understand the challenges here of trying to treat a patient who is now going against and contradicting every aspect of the regenerative treatment you're trying to perform. So, of course, a balanced diet is the most obvious thing. And too often we ignore the value of a balanced diet in order to get what we require in order for this machine to run effectively. If you need to look into supplementation, for a smoker, you may be looking at a 250 milligram tablet of vitamin C for every cigarette that they have. Normally people will laugh at this because vitamin C saturation is diarrhea, chronic diarrhea. But you never reach that point of saturation because the cigarette's depleting your recommended daily intake of that. Otherwise, you may look with a diet or through supplementation of around about 1,000 milligrams taken per day. So this is one element for maximizing your collagen potential. The other element that we need to take into account, the extracellular matrix is a lot like springs that you find in a mattress. They can stretch, they can bend, they provide support, they can bounce back, they might not bounce back as well. So for this effect, it's a lot like a triple helix here. So the tighter bound this rope-like structure is of collagen protein fibers, then the better the durability and the better the strength is going to be. So like springs, it's going to bounce back a lot more effectively. Particularly for female patients, if they are anemic or if there is an element of iron deficiency, this takes your tightly bound rope-like structure to now a very loose and weakened collagen. So without this durability and without this scaffolding effect, this means that you will lose elasticity, density, and create more pulling and sagging of the skin. The solution for this, of course, is iron. The recommended daily intake is 15 milligrams per day, whether this is medically diagnosed for anemia and then medically prescribed, or whether this is taken through supplementation. Please be aware, though, that the iron must be of a hemoglobin source for it to be recognized by the body. So for patients who are vegan or vegetarian, iron that is sourced from seaweed or sourced from marine extracts will not be recognized in this form. The next area I want to move on to is about communication. So zinc is renowned for its healing capabilities, but if you ask the average practitioner, tell me why it's good for healing capabilities, you'll notice that everyone goes blank. What we have here is referred to as zinc fingers. And zinc fingers enable the communication of RNA, but also DNA between the collagen fibers. The role of a zinc finger essentially is to enable a clear communication of consistent regeneration. So when, for example, you see scar tissue on the skin, then you know that the transcription broke down. You know that the communication broke down with this. Common signs of zinc deficiency, which is more common in younger males, is a prolonged blue or purple phase as the skin heals, whether that's acne, whether that's stretch marks, whether that's scar tissue. And so once we have this deficiency, then it breaks down the communication. So when we have a breakdown of blueprint, this means that there is a breakdown of the skin quality, the integrity, but also the blueprint for the extracellular matrix. The RDI, or recommended daily intake for zinc, is about 23 milligrams a day, but for male patients, you may wish to increase that a little bit higher. This is just a guide, of course. Medical advice should be sorted, or the advice of a dietitian or nutritionist to now tie all of this in. Can I remove this top line? The second most dominant cell that's found within the dermis is the macrophage. And the role of this is absolutely instrumental for your wound healing response. The macrophage accounts for around about 10% of cell composition. The macrophage is a phagocytic cell, which means that similarly to a crocodile, it's able to process a pathogen. As it processes that pathogen, we have the release of hypochlorous, the release of phosphoric acid, which then essentially disarms and then suffocates and kills the pathogen. So the role of the macrophage is instrumental for beginning your inflammatory and wound healing response. The quality of the macrophage, however, is also determined through diet. So quite simply, your macrophage is a lot like an ambulance, a lot like a fire engine, a lot like a police car that is going to react when there is major trauma. How quick and how effectively it reacts depends on the health also of the body. So looking at the role again of this machine and regenerative medicine, we are looking at no to low alcohol prior to treatments. You're also looking at no trans fats in the diet. If you perform PRP or take blood, you can see if it's poor quality, if it's cloudy, if it's fatty. And all you're doing is putting poor quality growth factors back into the skin. You also want to have a low inflammatory diet. So reducing inflammation, which includes alcohol, which also includes a reduction in sugar, and also includes a reduction of high spice or heat food. What also links in with this is an alkaline diet. And by re-alkalinizing, this then has the gastrointestinal tract back into its perfect position. So the small intestine works in an alkaline environment. The stomach, however, works in an acidic environment. And so with this, we can reduce inflammation, but we can also now promote balance, which means that the macrophage can react responsibly, which means that it is able to activate a more effective healing and repair mode. The final key cell group that you have within the dermis is the adipocyte, and this accounts only in this case about 5%. So you can see here there is a very big difference between no fibroblasts, a few fibroblasts, lots of fibroblasts. And now I move to the epidermis. This is interesting because traditionally, the medical practitioners have looked at this and said, why on earth would I touch there? There's no value. This is for the beauty market. It's too superficial. There's no pain. There's no blood with this. I'm going to disagree with this. The most dominant cell that you have is a keratinocyte. The keratinocyte accounts for 90 to 95% of cell composition. Keratinocyte undergoes a process of keratinization until the fully keratinized keratinocyte is then sloughed off as a corneocyte. If you have milia, you don't have a problem with a fibroblast. You have a problem with the keratinocyte. If you have acne, in addition to inflammation and infection, you don't have a problem with an adenocyte. You have a problem with the keratinocyte and keratinization. If you have hyper or hypopigmentation, you haven't got a problem with a collagen-producing fibroblast. You have a problem with the failing relationship between the keratinocyte and the melanocyte. The third most dominant cell only accounts for just 3% of cell composition, but it is surprisingly powerful. And this is the melanocyte. The melanocyte is found in basal epidermis. The melanocyte is dendritic, which means that it uses dendrite arms to hand over a pigment capsule, which is called a melanosome. There's a mathematical equation to this. Roughly about 1 melanocyte has the capability to then impregnate or hand over the pigment capsule to about 36 to 42 keratinocytes. The exchange of the pigment occurs from melanocyte into the keratinocyte and then occurs in spinosum. What I want to show here for standard epidermal hyperpigmentation, you need to be exact. Your microdermabrasion at corneum will not work. Your very superficial healer granulosum will not work. But neither treating all the way down into the dermis is going to work. Your problem is specific to basal spinosum. This is epidermal pigmentation. We also refer to dermal pigmentation. And dermal pigmentation is going to include recalcitrant melasma. We start moving into other conditions such as dyschromicum persistans, otherwise known as ashy dermatosis. And we can also see other forms of dermal hyperpigmentation through diseases such as Addison's disease. What I'm going to show here is instead of the pigment capsule being handed up, the pigment begins to take presence into the epidermal junction and also the very superficial papillary dermis. Melanin should not be there. And so when melanin should not be there, it's going to be viewed as a pathogen, which means it needs to be processed and removed. The cell which does this is a macrophage. When you have pigment-containing macrophages, we call this a melanophage. And the melanophages are clusters of darker pigment which sit in either the epidermal junction or very superficial papillary dermis. The reason why I'm drawing this up is because you need to identify what you've got. If it's epidermal, then your needles are going to be targeting here. But if your pigment is dermal, then you need to be targeting through this section here where you have clusters of melanophages. At this point, you're looking at this going, wow, this is great, this is amazing, I'm learning lots, but what depth? Depth is not a number. Depth is about what you see. So let's talk about blood. There are no blood vessels in the epidermis, but you have blood vessels in the dermis. The vessels in the dermis, by comparison to those found in the hypodermis, are smaller in size but more frequent. The ones in the hypodermis are less frequent but larger in size. How do I know with pinpoint precision for every patient, every procedure, every time when my needles are? It's based on what you see. Starting corneum, there are no blood vessels in the epidermis, so you will see no blood, but you will also see no color change. Let's be realistic. You're also going to see no result. If you were in granulosum, you're going to activate some inflammation. So as such, you're going to see no blood, pink skin. As you hit down to basal epidermis, particularly for epidermal pigmentation, no blood, but the skin's going to be red. The vascular activity that we see for papillary dermis here, you can see horizontal vessels, but the fibers which connect the epidermis into the dermis here, you'll notice that there are some vertical vessels that come through. So particularly for the treatment of superficial melanophages, then you would be looking for the occasional pinpoint blood. But once you start touching into the major vessels of the dermis, you're going to be looking for consistent pinpoint blood. And as your needles penetrate down into the larger vessels, then you're going to see moderate blood. So if I want to treat epidermal pigmentation, I know that my visual endpoint is no blood, red skin. What do I do if I see pinpoint blood? Turn your needles down. Likewise, also, for all collagen induction therapy procedures, you need to see a minimum of pinpoint blood. There is no such thing as a baby Dermapen procedure. There is this obsession from patients who believe that you can start off doing a more superficial procedure and build your way up to the deeper ones. That does not exist. You either hit fiberglass and get a result, or you don't. So with this, if you don't see any blood and you want it, then simply increase your needles. So now you can customize from region to region to region to region, but also from patient to patient, from day to day, from diet to diet, moment to moment, for the ultimate tailored procedure. So with this process, what we've now established is depth is not mathematical, depth is visual. But we've also established that through these key cells, we've opened up the opportunity for the indications that you can successfully treat with Dermapen. Firstly, when you have an imbalance of keratinization, add in inflammation, add in infection, you're going to see acne. So you can safely treat and target through the epidermis here, acne stage 1, which is comedonal, acne stage 2, papulopustular, acne stage 3, which is nodular cystic. I don't recommend that you treat acne stage 4, which is acne fulminans or acne conglobata. Many practitioners will think, hold on 1 minute. If you microneedle over the top of active acne, then you're going to spread acne bacteria all over the face. That is absolutely impossible to share with you. Number one, to make you sound like the smartest practitioner on the planet, Propionibacterium acnes was fired in 2018. We don't use that term anymore. So P. acnes bacteria, unfortunately the Latin's not so good for the English, but it's called Cutibacterium acnes. Cutibacterium acnes, or P. acnes bacteria, we all have. So with this bacteria, with my ambition here, I want to show that P. acnes or C. acnes bacteria we all have. This is my interpretation of a follicle, work with me. You then have your sebaceous gland outside, work with me. And this contains C. acnes bacteria or P. acnes bacteria. It lives in an anaerobic environment, which means it's oxygen free. When retention hyperkeratosis or clogging and congestion takes over, that means that now the follicle, which harbors oxygen, now too becomes anaerobic. So that means that the Cutibacterium acnes can make its way into the follicle. You then have an infestation of bacteria and then pressure, inflammation, so on and so forth. So if your bacteria is anaerobic environment, it's a lot like catching a fish. If you take a fish out of water, it's going to suffocate and die. If you add oxygen to an anaerobic bacterium, it's going to suffocate and die. So what occurs with the process for the treatment of acne is oxygenation, which kills C. acnes bacteria or P. acnes bacteria. When you kill that, it then forces the reduction of any associated Staphylococcus epidermidis. So treatment of acne is absolutely possible. You can also treat milia, keratosis pilaris. We understand that for hyper and hypopigmentation, the pathophysiology, or what's gone wrong, is your relationship between the melanocyte and the keratinocyte. So with this, the melanocyte, it only counts for just 3% of cell composition, but it has this immense power. So we understand that you would be able to treat for your epidermal pigment, which includes facultative hyperpigmentation, that's your generalized dyschromia, uneven skin tone. Then moving into lentigines, which is clusters of melanocytes with broken dendrite arms joined together. You can also treat ephylidase or freckles, a genetic predisposition that is more dominant in this part of the world than anywhere else. But you can also treat post-inflammatory hyperpigmentation. Depending on position, if your pigment then becomes dermal, you can then begin treating issues such as melasma, but also pigmented poikiloderma, which is where we see a combination of collagen thinning and attack, an increase of vascularization, but also dyschromia, hyper and hypopigmentation. As part of a regenerative procedure that's relying on regulatory growth factors, and we'll explore this in a moment, to achieve balance, if you have too much pigment, hyper, then you can also achieve regulation when there's not enough. That's hypo. So we can achieve success for guttate hypomelanosis, which is the white spots that will occur after chronic sun exposure. You'll be able to treat for post-inflammatory hypopigmentation. Moving into dermatological concerns such as chemical leukoderma, and then as part of drug combination therapies, either vitiligo vulgaris, generalized vitiligo, or acral vitiligo. So with all of these indications, ideally you are looking at no blood, pink to red skin, with the exception of dermal pigmentation, which is going to be just the occasional pinpoint blood. For your dermal indications, you must draw pinpoint blood as a minimum. If you don't, then for your collagen induction therapy, you will not activate a fibroblast. So you will need to draw pinpoint blood for your anti-aging procedures, your regenerative procedures. You will also need to do this for your scar procedures. With your scar procedures, we have options of what you will be treating. For example, you may have post-acne rolling scars, which are wave-like undulations following superficial acne. You then have post-acne boxcar scars, or you could have post-acne post-seborrhea ice-pick scars. An anatomic scar is a pock mark. The most common reason for this initially was smallpox. That shouldn't be so common these days. Smallpox inoculations, common, but syphilis also creates anatomic scars. We then also see success moving into hypertrophic scars, where you have a raised but controlled trauma. And then also keloid scars, which will require a medical combination to achieve success. Of course, we see success also then moving into stretch marks. For your scars, for an easy way to understand where you need to be treating, look at color. If the scar is red, blue, or purple, then that means that this vascularity that should be in your dermis is still relatively intact. But if your scar is either very white, if it's very old, or for a darker Fitzpatrick, it's very, very dark, it means that this vascular activity has been pushed farther and farther and farther down, or it doesn't exist. So you'll need to target deeper. So red, blue, purple, here. White or black, here. We then lead into areas for treatment of stretch marks. Striae distanceae is where you have changes based on elasticity. Gravidarum is from pregnancy, and then atrophicae is from systemic or topical steroids. Rosacea is an interesting area because rosacea is not just over-vascularization and angiogenesis through here, but we have an inflammatory disorder which then sees the attack of both the dermis but also the epidermis through the release of MMPs or matrix metalloproteinases, elastinase, collagenase, which make everything thin. It also attacks the epidermis. To simplify, if I can see your vessels here, then I can see all the way through your epidermis into your superficial dermis. You have a very thin skin. So if we can actually dermapen to redensify, but to then also control the angiogenesis, then we can see a result for stage 1 papulopustular rosacea, stage 1 erythema-telangiectatic rosacea, stage 2 papulopustular rosacea. This used to be called acne rosacea. It's got no connection in with acne. And as part of drug combination therapies, phimosis rosacea. With this, we can also see success for telangiectasia and for very mild cases of alopecia. But for true alopecia, we understand that the follicle is positioned in the hypodermis. The bulb receives the nutrients through the hypodermic vessels. So the only time that you ever need to deliver moderate blood is particularly for striae or scars that are white, very dark, or old. This is also the case for all types of stretch marks. You can also treat for cellulite. Cellulite has nothing to do with toxins. Cellulite is about herniation of adipose tissue coming through here, which then creates an abnormal positioning of the overlying tissues. But otherwise, part of drug combination therapies, we'll need PRP as a minimum. We see success for tractional alopecia, cicatricial alopecia, androgenetic alopecia, which will require further topical and systemic drug combination therapies, and then alopecia areata and telogen effluvium. Now that we've opened up the opportunity and understanding that Dermapen is more than just wrinkles, it's more than just stretch marks, it's more than just scars. Now that we've understand that it's not mathematical, it's about a visual endpoint, I now want to look at one of the more controversial areas, which is treatment frequency. The reason why this is controversial is because you'll see practitioners which say treat every week, every 2 weeks, every 3 weeks, every 4 weeks, every 5 weeks, every 6 weeks, every 6 weeks, 7, 8 weeks. Who's wrong and who's right? The skin's right. You either work in with the body's wound healing response for a benefit, or you work against it and you're going to have a problem. The body's wound healing response is broken up into 5 subphases. We have hemorrhage, blood rushes through, hemostasis, seals off, and then our classic phases of inflammation, proliferation, maturation. Each of these have a very set time. If you work with it, then you have the ultimate of regenerative medicine. If you work against it, then you're going to activate the trauma mode. Your Dermapen procedures are fractional. Your Dermapen procedures are regenerative, autologous, but also they leave the epidermis intact. So we're not looking at an ablative or traumatic procedure. The first area of consideration is the inflammatory response. We have a microtrauma, but what's unique to this is microtrauma, but no blood. That microtrauma will instigate, in Latin, dolor, calor, rubor, tumor, frontier liesa. In English, pain, heat, redness, swelling, loss of function. There's 2 key areas I want to focus on with the inflammatory response. The first is called chemotaxis and phagocytosis. So hemorrhage, blood rushes through, hemostasis, seals off. Neutrophils or phagocytic cells will then begin to stick to the vascular wall. They then begin to roll, And as they roll, the vascular wall then becomes permeable, and then they're able to work their way up and out. So your phagocytic cells can then remove the pathogens. The better the quality of the diet, the better the quality of the machine, the better the quality of phagocytosis. So chemotaxis is the movement of a chemical within the skin. So your phagocytic cells up and out. And then phagocytosis is the removal of pathogens. The second key element, this is the reason why your Dermapen works for so many indications, is the release of regulatory growth factors. Growth factor is a word that's thrown around a lot. So the growth factor is an agent that is able to manage, direct, guide, regulate, balance any chemical message or signal. For example, if my pituitary gland sends out a message which is melanin stimulating hormone, and that message is produce more pigment, produce more pigment, produce more pigment, produce more pigment, then melanocyte growth factor can say, yes, let's make more pigment, or no, we're fine, we have enough. So we have this balancing act here. We could talk about potentially hundreds upon hundreds of thousands of growth factors here, but I want to narrow it down to 7 key growth factors you need to know. The big boss of all epidermal function and the big boss of everything that occurs here is called epidermal growth factor. What manages keratinization is keratinocyte growth factor. But interestingly enough, more up-to-date studies show that keratinocyte growth factor is crucial in communication with fibroblast growth factor for collagen production. So these growth factors also talk to each other. We then also have melanocyte growth factor, which determines what's too much pigment versus what's not enough. A melanocyte also is an immune cell, so it's more than just pigment. The big boss of all biological processes within the dermis and the hypodermis is a family called transforming growth factors. What manages collagen type, collagen form, collagen placement, collagen regeneration and transition is called fibroblast growth factor. And then what manages this vascular activity in the dermis and hypodermis, vasodilation, vasoconstriction, angiogenesis, is vascular endothelial and platelet-derived growth factors. These are all released as part of an inflammatory response, trauma, without necessarily drawing blood. Biologically, there's 2 forms of inflammatory response. You have an acute inflammation, it's fixed, it's resolved in 1 to 5 days. Or you have chronic inflammation, which is biologically fully resolved in 10 to 14 days. Let's say 2 weeks for ease. So if the inflammatory response is fully resolved in 2 weeks, then it means that you can treat any of these superficial inflammatory epidermal indications as frequently as every 2 weeks. If the patient says to you, I can't afford that, not a problem. Stretch it out to every 3 or to every 4 weeks. Don't treat any sooner, because then you take your controlled and resolved inflammatory response into new territory of trauma. Try to avoid going over the 4-week mark, because you're going to lose the continuum. You're going to lose the momentum that you get of increasing the growth factor release and then a cumulative reactivation of that growth factor release. The second area for consideration is the proliferative response, which is where we see collagen production come through. The proliferative response is where we see scar tissue potential. Scar tissue has a very, very bad reputation. And with this, I want to change your mind slightly. Scar tissue has a very key purpose. Work with me on this story. If I'm a caveman and I get attacked by a dinosaur and I have a big gash down my chest and shoulder here, in caveman times, there's no hospital. In caveman times, there's no pharmacy. In caveman times, there's no bandages, there's no antibiotics. So what are you going to do? Scar tissue. What scar tissue will do, it's a rapid collagen release that's called cicatricial healing. So cicatrice in Latin means upside down. And what's going to happen is we see this abnormal placement of mature, thickened collagen to try and re-epithelialize and to close up the treatment area. So cicatricial healing or scar tissue is in fact a little bit ingenious. It's our body's way of protecting ourselves. The problem is though, aesthetically, it's not so pretty. So with this, what activates scar tissue is a group of, shall we say, bad growth factors called pro-fibrotic growth factors. So when you burn the skin, when you over-traumatize it, when you cut it, when you ablate it, when you damage it, to such a degree, it reacts. We all react in this way. So irrelevant of your background or your skin color, everyone has the potential for producing scar tissue. What produces the scar tissue is a precursor called a pro-fibrotic growth factor. This is called transforming growth factor beta 1, transforming growth factor beta 2, or heat shock protein 47. In addition to the release of the pro-fibrotic growth factors, you'll also have an imbalance of the melanocyte growth factor, which means not only do you see scar tissue, but what you're also going to see is either post-inflammatory hyper or post-inflammatory hypopigmentation. By contrast to a major trauma, your Dermapen is a fractional treatment. The epidermis remains intact. You have 1,920 puncture channels per second in the skin. This instigates a very different biological response, and we call this scarless wound healing. This begins by the placement of immature type 3 collagen into the site of trauma, and then the role of epithelial cells to re-epithelialize more superficially. So by contrast to cicatricial healing, you have the right cell in the right position doing the right thing. Pros and cons. Type 1 collagen is durable, it's strong, it's tough, it's resilient. Type 3 collagen is very, very weak. There's no strength to it. However, for the average adult, over a 6 to an 8 week time period, you're going to see the transition of the collagen from the immature type 3 into mature, strong, durable type 1. This process now allows for a regenerative proliferative response that is not cicatricial. So it's a scarless wound healing. Because for the average adult, it takes 6 to 8 weeks for this collagen transition and development, that therefore dictates that for any procedures you are drawing blood, from anti-aging to your scar treatments, to your striae treatments, to your rosacea procedures, you're going to be performing these every 6 to 8 weeks with pinpoint blood as your minimum. That is also the case for your hypodermic procedures. So as a part of this, what happens if I go sooner? When you start over-treating, irrelevant of your background, your body goes into trauma mode. And when your body's in trauma mode, you're going to risk cicatricial healing, but risk also the release of pro-fibrotic growth factors and an imbalance of melanocyte growth factor. When you go over the 8 weeks, again, you lose that momentum. So with this, what you want to do is to create a perfect treatment program. Your body's wound healing response then leads into maturation, which concedes the maturing and the development and transition and remodeling of the collagen for anywhere up to 2 years after treatment. So I want to show here that your best results are not tomorrow. Your best results are not next week. Your best results start laying the foundations maybe at week 2, but continue on for week 4, week 6, week 8, week 12, and continue on for anywhere up to 2 years. So I want to show here that treating more superficially does have value with your Dermapen 4. I want to show that the epidermis opens up new opportunity for acne familiar, for keratosis pilaris, hyperpigmentation, and hypopigmentation as well. When you treat more superficially, because you can see the patient as frequently as every 2 to every 4 weeks, you also have profitability. When you also do this, you can also increase your treatment intervals and play around with your treatment program. For example, if someone comes in and they have a very aged skin plus pigmentation, there are 2 issues here. Or they have active acne and acne scars, you can actually alternate your treatment depths. For example, first treatment, draw blood. So you target pigment, but also collagen. Then, if your patient has minimal money, then you could reperform that in 6 to 8 weeks' time. If your patient has more money to spend with you, first treatment, draw blood. Then 3 to 4 weeks later, go superficial. Then you directly target the pigment without over-treating the collagen-producing cell. So by changing your treatment programs, and alternatively, if your patient has lots of money, for an 8-week program, it could look like blood. 2 weeks, no blood. 2 weeks, no blood. 2 weeks, no blood. 2 weeks, blood. Then it means that you're not treating more frequently your dermis and hypodermis than every 2 weeks, than every 6 to 8 weeks, but it also means that you're not over-treating your more superficial epidermis more frequently than every 2 to every 4 weeks. So you can play around with the programs. Likewise, also, I want to show that with a post-operative application of camouflage, this is called DpD Dermaceuticals Cover Recover. It's more than just a broad spectrum SPF 30 PA++. It's in a base of 3 types of re-epithelializing silicons, plus a thermoregulator to remove heat, and also a probiotic to now promote bacterial balance. This can be applied immediately after treatments. The patient can even sleep in it. So this now means that your patient can leave looking as if nothing had been performed on their skin. This opens up a whole new other area for topical local anesthetic. And with this controversial area, I choose not to use it for most procedures. This is controversial because everyone's like, what about pain? Firstly, from a pain perspective, your pain receptors include Merkel's cells. Merkel's cells are found right throughout the epidermis, but they tend to focus more around granulosum. A Merkel's cell will register experience, will register moment, will register vibration, but it's not going to register physical sharpness or pain. What does this are your mycin corpuscles, the Virginian corpuscles, and frequent appendix, which is sitting through around about basals and comes up to stelocin. So I'm going to show you that for your general epidermal procedure, you're not actually really touching the physical nerve or pain receptors. So you do not need topical local anesthetic for this. Moving on down, if you use topical local anesthetic, bear in mind that it's going to require half an hour to 1 hour to process. But your Dermapen only takes 3, 4, 5 minutes to treat on the face. So your accountant's going to look at this and say, that does not make sense. And you're going to look at the treatment and you're going to have to increase your price significantly to take into account the 30, 45, or 60 minutes for the anesthetic to process for the treatment that only takes 3 to 5 minutes. The other consideration for this is because it's oscillating at such a fast speed, 120 revolutions per second, that vibrational oscillation will dissipate the nerve receptors. Vibrational therapy is very, very common for injectables. So you don't need anesthetic. You create a vibration, dissipate the nerve receptors, in goes the needle, the patient doesn't feel anything with this. So the speed of your Dermapen 4 device becomes instrumental as well. The other challenge with topical local anesthetics is their response on the skin. I'll finish this topic and then we will take a break and I will move into, we'll run a little bit late, but I'll move into the other topics after break and then we'll catch up. There's 2 families of anesthetics. You have amides, which includes lignocaine, which is also the same as lidocaine. This includes prilocaine and also bupivacaine. In general, amides are great for surface area, but they're not so good for depth when applied topically. So even if you're using a high lidocaine cream solution, if you're doing scar work or deeper work, it's not really going to help you that much anyway. What gives you depth is called an ester. And the most common esters include tetracaine, but also benzocaine. There are reports that up to 18% of patients will react to an ester anesthetic in the form of a contact dermatitis. That's problematic. So if the patient says, my skin is itchy, it's dry, it's flaky, it's not you, it's not your pen, it's your topical local anesthetic. Likewise, also, particularly tetracaine is a known vasoconstrictor. So if you're trying to draw blood, but your topical local anesthetic is preventing blood, this is going to make your treatment compromised. The other issue when I look at the anesthetics, pilocaine can be associated, studies from Southeast Asia, with post-inflammatory hyperpigmentation. But the reality is, if your Dermapen is working so quick that the forehead absolutely can be uncomfortable, but it's over and done within 12 to 17 seconds. So we look at the relationship of speed and slight discomfort and slight scratchy sensation versus the complication of adding all of this in to the equation. You'll probably go back to clinic and look at your topical local anesthetic and determine which ones do you have and which one is going to be a benefit or complication for that. It's easy, it's all got to do with spelling. All amides always have two I's in the formula, L-I-G-N-O-C-A-I-N-E. These aren't so problematic, but they're time consuming. All ester anesthetics when we have one in the formula. These are going to be problematic for vasoconstriction, but also for reactivity of the skin. I've got 2 minutes to get this finished. So, looking at contraindications and considerations, there are absolutely no surprises here. I really want to compare the difference between what is active versus what is inactive. So the most obvious thing, if someone has hemophilia, if someone has a thrombocyte or a clotting issue, technically they would be on medication for this. So get the doctor's go ahead. But otherwise, if your patient has an undiagnosed solar keratosis or actinic keratosis, get it checked out. Undiagnosed moles, undiagnosed pre-skin cancers, get them checked out first. Otherwise, if your condition is in active phase, including herpes simplex, scleroderma, collagen vascular diseases, this includes Ehlers-Danlos syndrome, vitiligo, active warts, bacterial infections, of course you are not going to treat. But if it's no longer active or it's stabilized, then there is the possibility to treat. The only things I'm nervous about are collagen vascular diseases. This includes Marfan syndrome, Ehlers-Danlos syndrome. Have a chat to their doctor. The other one I'm concerned about is also psoriasis. We can create what's called keratoconization, which means you treat up here, but the psoriasis reactivates in another place of the body. But otherwise, generally, once you have stability, these are not such a problem. Just some considerations. For pregnancy, it's up to you, it's up to the doctor of the patient. So you may wish to avoid topical local anesthetic, you may wish to avoid certain mesotherapy ingredients for that, or you may wish to wait for this. For any patients on arrhythmia medications or any anesthetic allergies, of course, you're not going to use any topical local anesthetic on them. Autoimmune diseases, if it's active phase, no. But if it's now in remission, in some cases up to 6 months, then you can treat. Be aware that blood thinning medication is not a problem. It just means that you bleed easier. So be aware also through supplementation as well as prescribed medication. To give you some rules, but I'm also going to break the rules. For an inexperienced practitioner, botulinum toxin, fillers, give it 2 weeks either side. But it is possible to combine them into a single procedure, but I won't give you the protocols for that yet. Likewise also, if you do laser or a medium depth chemical peel and you have scabs and flaking, then wait for those scabs and flaking to remove, then give it 2 weeks on top. So normally you would go Dermapen, 4 weeks, then you can do the other procedure, wait 4 weeks. So you'd be working at a 4-week alternation. Otherwise, for simple things such as microdermabrasion, hydroabrasion or wet microdermabrasion treatments, these can be added in, but sensible time periods, whether that's a week. But generally, if there's scabbing or flaking, wait for that to remove, then give it another 2 weeks on top before combining in with Dermapen. You can use your active skincare right up to the day of treatment, and then you will follow your post-op non-negotiables for DpD dermaceuticals for at least 4 to 5 days post-op. Let's take a break now for morning tea. So we've got 15 minutes, and then we will move into some new topics, and we will break for lunch at 1:30. So I think tea and coffee's set up. Have a breather, step outside, because the information is going to take some time.
I'm okay, thanks, Laura. Thank you.
Now that we've established depth is not mathematical, it's visual. Now that we've established that our Dermapen is more than just scar revision, and establishing that we can be far more precise and exact with our procedures by working with the body and understanding essential skin 101, and I want to move into advanced techniques and ways to physically use the Dermapen to now create even further pinpoint precision depending on what you're going to treat. For your standard procedures and for any standard automated microneedling procedure, you will always need a lubricating, facilitating glide applied onto the skin first. This does not include saline solution. It does not include just plain PRP solution or just a water-based solution or dry skin. Because if you try dragging the needles across that, it will not create comfort. Using saline, it will create resistance, the same with PRP. So we understand that you need to facilitate this device, facilitate the needles by providing a gliding medium. The standard gliding technique for Dermapen 4 is verticals, followed by horizontals, diagonal 1, diagonal 2. When is going to be appropriate to use this technique? All standard Dermapen 4 procedures are going to be a gliding technique. So a standard procedure, I mean for someone with basic skin rejuvenation, anti-aging, for pigmentation, for simple acne, for rosacea, for simple scar work. So for all of these techniques, you will be using your gliding technique. So to specify further, so a standard procedure, getting into categorizing systems. The Global categorizing system determines how wrinkled someone's skin is. So it's 1 to 4. So for mild wrinkle depth, when there's mild topographical changes or contrast, so we'll go 1, 2, and moving into the early 3s, use your glide technique. Another system that measures aging, there is also a Fitzpatrick system for this, but this one goes 1 to 3. So it's the same Dr. Fitzpatrick for the Fitzpatrick phototyping, but he also has a system that goes from 1 to 3 for how severe wrinkles are. So if we're looking at mild to moderate, 1 and 2, you can use your gliding technique. For scars, there is a categorizing system called Goodman-Barron. And this will determine how much contrast you have, whether there is mild or whether there's a big contrast between atrophy or hypertrophy. So if it's mild to moderate, which is a Goodman-Barron 1, 2, and early 3, the system is from 1 to 4, by the way, then you will use your standard gliding technique. So minimum to moderate wrinkles, mild atrophic scars, mild hypertrophic scars, uneven skin tone, hypopigmentation, telangiectasia, rosacea, because you're not going to have contrast, all that. You're going to need to apply a gliding medium. I'm going to cover the MG collection after this topic in greater detail. But the design of the DpD dermaceuticals for your infusion will lubricate the skin, allowing for increased comfort, but for you to also operate quickly and fast. To maximize your gliding technique and to work quickly and fast, then you would want your Dermapen on speed 4. I'm very aware in the market that people will say, hold on, Dermapen 4 is noisier than other devices on the market. What's the point? If you look at a Formula 1 race car, Ferrari, and listen to it, it's also noisier than a Toyota Yaris that's driving down the street. So with this, I want to associate the noise with speed, power, intensity, infusion, and success. So Dermapen on speed 1. You need to get somewhere quickly. So you need to get from here to Dublin in as quick as possible. So you could either walk, it will get you there. Speed 2 is bicycle. Speed 3 is car. Speed 4, use needle cartridge, is your private jet. So I want you to associate the power and the noise with comfort, with speed, efficacy, but increased infusion. So the higher number here at 120 revolutions per second now equals an unprecedented 1,920 per second. And using this striping technique, this now means that the epidermis remains completely intact. It means that you still deliver a fractional procedure, and it now maximizes your comfort. This is how the procedure is going to look. So we apply the MG collection, so lubricating glide produced by DpD dermaceuticals onto the skin first. The patient's going to do the supporting for us. Vertical. Horizontal. Diagonal 1. Followed by diagonal 2. So you can see they're actually dividing the face up into different areas and zones. So with this process here, you're not doing tiny little stars on the face of vertical, horizontal, diagonal 1, diagonal 2. You're going to treat a large area. So I would look at, say, the forehead, then the chin and jawline as a full treatment area, the cheeks, the eyes, the nose, the upper lip or the lips themselves. Your order doesn't really matter, so long as you reach your achieved visual endpoint, the one that you wish to have, but also so long as your technique is exact. Vertical, horizontal, diagonal 1, followed by diagonal 2. So this is your standard gliding technique. What about if you need something that's far greater precision? The surgical market would say to you, why do I want microneedling? I have subcision. Subcision is a 18 gauge tri-beveled needle, so it's incredibly thick. I want you to think like a nail, so twice the size of this. It's then inserted into the skin and fanned to break up scar tissue. It's very practitioner reliant. It's a very old-fashioned style of treatment. It's very painful and there's a lot of bruising. With your Dermapen going up to 3 millimeters, you don't need that style of technology. It now opens up new opportunities. You would then also look at something such as the microneedling roller and stamps, which used to be at 3 millimeters for that. And again, you don't need that. So we look at imprinting technique. Imprinting is not the same as stamping. Stamping looks like this. So it's practitioner dependent. And again, you can't change your needle depth. Imprinting is where you're going to set a concentration of needles, which either at your scar treatment setting is 60 revolutions per second, which equals 960 puncture channels per second. So what you can do is actually hold for 3 seconds, 1, 2, 3, needles out, and then re-support and re-angle the skin. 1, 2, 3, needles out. So you can do that by supporting and holding, enabling a three-dimensional way to break up the tissue. So vertical and then coming in through the sides. This is going to work for very deep wrinkles. This is also going to work for hypertrophic, but also for deeper atrophic scars. If your scar treatment setting is too deep, and for many cases 3 millimeters is too much, then all you simply need to do is adjust to whatever your depth is going to be, let's say 1.25 in this case, but keep it at the lowest speed setting. So you're not using gliding technique with this, you're actually going to hold it. 1, 2, 3, needles out, re-angle, and then at a 45 to 65 degree angle, 1, 2, 3, needles out, 45 to 65 degree angle, 1, 2, 3. And you do this until you achieve your desired visual point. What happens if you set your needles, and at 2.5 millimeters, I think this is going to be correct, and remember that your scar tissue, because it's cicatricial, is upside down. So the bulk is sitting up the top and then it filters down. So if you need to break through that initial scar tissue, you may want to use your imprint technique, say at 0.5. Break through the initial tissue first. So now we're through the epidermis. Now to get into dermis, let's say 1.25. 1, 2, 3. The angle, 1, 2, 3, until you can get down to exactly where you need to be. So it's no surprise here that you're looking at more severe issues here. So for a Glogau classification system, a Glogau 3 to 4, very, very deep wrinkles. Fitzpatrick classification system, number 3, very deep wrinkles. A Goodman-Barron scar classification system, 3 to 4, very atrophic or very hypertrophic scars on the skin. So you've got prominent severe wrinkles, prominent severe atrophic or hypertrophic scars. Please note that you do require a drug combination therapy to treat keloids. Do not go straight in with just Dermapen. You will still require a gliding medium for infusion, but for also movement, but you can adjust. So speed 1 is 66 revolutions per second, 1056 holes per second, or if you automatically go to the scar treatment setting, you then have 60 revolutions per second and 960 punch channels per second. So this patient's been treated with glide technique first. Now for concentrated, tight, fibrous clusters in the skin for post-acne scars, we go in 1, 2, 3, and then a multi-angle following. Because you need to support the skin for this, just make sure that your fingers are not at risk of needle stick injury. The patients report that because there's actually less needles with this, it's a similar sensation as if you were performing a glide technique. So your glide technique is very, very fast and evenly distributed. For this, there's less needles and just more localized distribution. So there may be some scratchiness, maybe a tiny bit of sharpness, but it's still tolerable. So this technique will serve as an ingenious way to update your traditional gliding, but also give you pinpoint precision depending on the indication. Now what I want to do is open up a new area of combination therapies with the DpD Dermaceuticals MG collection. Ever since the advent of the first microneedling devices in the 1990s, there's always been this hope, desire, want, estimation hypothesis that maybe those needles could also be used to introduce an active substance into the skin. whilst this hope or this hypothesis has never been successfully proven with other devices, I have the evidence here for Dermapen 4. We understand that if you apply a topical solution onto the skin surface, it will not be able to break through the acid mantle or barrier function. So human skin is not a sponge, despite what the average consumer believes. So this is what it looks like when you apply an aqueous solution. It just sits on the skin surface. These biopsies were performed by an American pharmaceutical company which produces anti-mitotic drugs. They were essentially exploring what would be the most advantageous way to get the drug into the skin without creating collateral damage and guaranteeing that it was in the right layer of the skin. So, of course, we understand, particularly with the medical market, that if you inject something into the skin, it will indeed go in, and it looks like this. So you can see precisely where the needle's gone in, the plunger is pushed, and you have a small collection of product here, which is what we call a bolus. So no surprise that an injection does indeed introduce an active substance into the skin. Well, what about microneedling? With Dermapen 4, the needles are solid. They're not hollow. So does this create a benefit? What happens if the patient bleeds? Because you're going to hear a lot of feedback from medical practitioners saying, if blood comes out, then the blood's going to push whatever you try to put into the skin back out. Well, here's the evidence. So this is at 1.5 millimeters, multiple passes, but you can see with physically 1,920 puncture channels per second into the skin, that number surpasses what we see with an injection. But what it also does is the mechanics and the physics will physically force and push an active solution into the skin, but with far greater capability than a traditional injection. This is called nappage or point-by-point technique. So this can be done with an individual needle, and generally you can see mesotherapy guns, which may inject 5 needles with this. So really we're comparing, say, 1 injection every 3 seconds, or maybe 3 injections every 2 seconds if you use a gun, versus nearly 2,000 puncture channels per second. So the mathematics is very clear that Dermapen will indeed deliver an active solution or substance into the skin. This is supported by world-leading dermatologist Sultani Shahi, who says that we have an excellent dermal delivery system, but what we also see that the evidence, based on the mathematics, that we can infuse that solution with far greater capability than the traditional syringe. The challenge here is the modern patient quite often has needle psychology. Needle psychology is where they feel that they've not undergone a medical procedure, or their medical procedure has not been valuable, or their money well spent unless a needle has physically gone into their skin. We need to be able to change the perception of both medical practitioners, but also the patient, to understand that you can now deliver an active solution or substance into the skin with far greater comfort, far greater efficacy, and far greater distribution and administration with Dermapen, even by comparison to traditional injections. So this now opens up a new area. Mesotherapy was coined in 1958 by a French practitioner, and essentially it's delivering biomimetic or skin recognizable ingredients into the skin to feed and add nutrition for this. So the combination of this now means that we have Dermapen for your autologous regeneration, so growth factor release that will increase growth factor concentration and potential by about 5 to 7-fold. Then moving into collagen production, angiogenesis, in addition to all of our regenerative benefits. But now by adding in mesotherapy, we can now physically choose specific ingredients and combinations to deliver into the skin. So with that, based on your visual endpoint, you can deliver that precisely and exactly where it needs to be so that you can create a better response as part of your cell activation and as part of your infusion procedure. For your base procedures for non-medical practitioners, it's going to be what's called the NG collection from DpD Pharmaceuticals. But for medical practitioners, this can then move into PRP, into nanofat, and then also into drug infusion, including steroids and antimitotics, and then also working in with microbotulinum toxin, which is called mesotox. Sultani Arad-Shahi, who I mentioned previously, who agreed that microneedling is indeed a very efficient way to deliver an active substance into the skin, also stated very obviously that just because you can put something into the skin doesn't mean that you should. And so some studies she conducted back in 2014 where she used common everyday topical serums that were then microneedled into the skin, 70% of test patients all came back with granulomas. That is when a foreign body is stuck within the skin. Can't go up, can't go down, can't go sideways, and now it's viewed as a pathogen. So with this, with these patients here from the study, patient B and patient C were on long-term systemic oral antibiotics for some 6 months after one microneedling. So I want to show that just because you can put something into the skin does not mean that you should just grab anything on your shelf. For patients who wish to microneedle themselves at home, you can't just grab your favorite moisturizer. You can't just grab your favorite serum and start microneedling because it will go in. And unless you understand the parameters of what creates safety, you have a real danger. So with this, if you don't know what system measures atomic mass or molecular weight, then you should not be needling things into a patient's skin. So a Dalton or a kilodalton measures atomic mass. So quite simply, if you force something into the skin that's very big, then it can't go up, can't go down, can't go sideways, and it's going to get stuck, look like this. What we also understand is that if your solution is not sterile, then you're going to risk infection. So a Staphylococcus aureus infection coming through. If you have the wrong form of a specific ingredient, although it may be good topically, let's imagine something like retinol. Retinol is a good ingredient topically, but if you start putting it into the skin, understanding its volatility, and that for most patients they need to build up a tolerance, you're going to burn the skin. But also understanding that if your product is resurfacing agents that are designed to work more superficially, if you start stamping in salicylic acid, if you start stamping in alpha hydroxy acid into the skin, you're going to cook the skin. So with this, we understand that there is more to microneedling and infusion than just using any product. There's got to be science behind it in regards to molecular weighting, in regards also to the product being sterile, in the right ingredient form. If it's too acidic, it's going to reduce the pH. If it's too alkaline, it's also going to change the environment of the skin's acid mantle, but also understanding that it's got to be in the right form to achieve the right response and result. All of this has been pre-done with the DpD Dermaceuticals MG collection. Firstly, the vials themselves are 5 cc's or 5 mils of sterile solution. The vials have a silicone nozzle up the top here, which means that if you choose, you can either distribute directly from the vial onto the skin. It means that as you apply that, the solution sits in the silicone nozzle, so it's easy to get out. You don't need to draw it up with a syringe with a needle. However, it's also lure lock compatible. So if you connect in a 5 or 10 cc lure lock syringe, it simply twists on over the top, and then you can draw up the product. There's a few reasons why you want to do this. Number one, it's easy to distribute. So you can perform full sterile procedure without having to touch the vial. So you can just release that onto the skin. Number two, for needle psychology, for patients who physically need to see something for them to feel that there's value, voila, they get to see a syringe. You can put a needle on the end of it if you want. You're not injecting with it, but it can create the theatre. But also with this, it means the patient sees the value that this is a medical procedure. This is not a beauty procedure. The other advantage also is that you can mix and match from your MG collection based on what you see. So you can simultaneously treat scars and aging, scars and acne, aging and pigmentation, all together by mixing, matching, and drawing different solutions from each other. The advantage of this means that you can further customize your Dermapen procedures based on what you see, based on patient spending patterns. So there's got to be a sales element here. You'll have high spending, but you'll also have patients who are not willing to spend as much with you, but now complete safe versatility. Everything is pre-blended, everything is pre-molecular weighted so that nothing can go wrong. It provides you with the ultimate guide for your Dermapen, which means a smooth, comfortable experience that does not trap or does not pull on the skin, but also delivers your active ingredients into the skin at the same time. What I like about this is for the beauty or the aesthetic market, this now opens up opportunity that they have never had in the past to now deliver a safe, predictable, reliable, active solution into the skin without the risk of granulomas, without the risk of vascular embolisms, which is where product gets stuck in the vessels, and without any complications. But what I also like about this is that you now have a fast method of administration that is injection-free. So absolutely no bruising, no increased downtime, but you can also use the MG collection to facilitate for PRP and to also facilitate other agents such as botulinum toxin for fast, quick administration and infusion without the needles, without the discomfort, and without the traditional bruising or downtime. Every single heat correcting product in the DP Dermaceuticals range features what is called a hyaluronic fuse complex. Hyaluronic acid is a very thrown around term within our industry, but understanding capabilities and manipulation of it really differentiates itself from just a stock standard HA. The HyalurFuse patent that we use is an exclusive patent which enables both penetration into the skin, but also opens unique opportunities for the hyaluronic acid. The development was produced by the world's leading medical producer and research and development agency for hyaluronic acid, which are based in the US. They're called the Matrix Biology Institute. And they've performed all the clinicals and the manipulation behind this. We understand under normal circumstances that a topical agent does not pass through the skin's acid mantle. However, if you manipulate the hyaluronic acid, so it's non-cross-linked, it's not the same technology as a filler, and if you make it so small, you can now create a unique capability that is not possible under normal circumstances. This is called a hematoxylin counterstain test. It's a third-party clinical produced at Monash University in Melbourne, Australia, to make this process easy. Hyaluronic acid has been molecularly weighted down to a very, very small size. It's been dyed grey. It's been applied in a gel form onto an intact human forearm. So no microneedling, no injections, no exfoliation, no other intervention. And then 20 minutes after application, a punch biopsy has then determined if the hyaluronic acid went into the skin, and if it did, how far did it go in? That's it. First image here, 20 minutes after application. our medium and small molecular weights have traveled down to basal epidermis. The third biopsy, 20 minutes after application, the smallest molecular weight, just through topical application, has traveled down to reticular dermis. We're very open about the weights and we're very open about hyaluronic acid technology. As such, hyaluronic acid is never measured in percentage. That's the sign of an ignorant practitioner. It's always measured in milligrams per milliliter. Don't just say milligrams because you can say any figure, but it needs to be milligrams per milliliter. We have 3 molecular weights. The largest is 1,800 kilodaltons. That sits superficially on the surface of the skin. The medium is 1,600 kilodaltons, which is this medium penetration through the skin's acid mantle. The smallest is 10 kilodaltons, which is so small that it will penetrate through the skin's acid mantle and take us down to reticular dermis. The advantage is that HA is more than just about water binding. The HA in this level will work to replicate and to enhance the extracellular matrix, but it also serves as an encapsulation or delivery system, particularly for water-based ingredients. So in other words, if we can create this level of infusion with just topical application, when you dermapen any product with the hyalofused complex, which is all corrective products, then you have an ease of distribution and free movement without any risk of granulomas or it becoming stuck. We have an unsurpassed concentration. I have yet to see any company exceed above and beyond 35 milligrams per milliliter. So we are the world leader when it comes to full concentration. The next delivery system also had origins originally in the filler market, and it's called a calfosome, which is the patent for the trademark. A calfosome, you're not going to find much on the internet search engine, but if you look for calcium phosphate, hydroxyapatite, or hydroxyl apatite, this is referring to the same ingredient. What we have is a microsphere that is able to physically hold and then infuse especially oil-soluble ingredients. So it's made up this sponge that is non-polymer, and the sponge is also non-liposomal. So it means that this organic sponge will simply break down into calcium and into phosphate within the skin. So there's no risk of irritation, there's no risk of granulomas. What we see here is the sponge of the calcium phosphate, which can then be infused, particularly with oil-soluble ingredients. It works in tandem with the hyalofused hyaluronic acid, but we now see penetration through the skin's acid mantle. What works uniquely with this is the skin's acid mantle, or the skin's pH, typically sits between 4.5 to 6.5. And so utilizing this acidity, then the calcium phosphate technology is then able to penetrate even more effectively. In addition to serving as a penetrating agent or a delivery system for oil-soluble ingredients, particularly retinaldehyde or vitamin A's, it also has the capability, as studies from Van Loden in 2015 showed, to activate fibroblast stimulation. But what it also does is stimulates what's called lamella granules. A lamella granule sits in stratum granulosum, and as it degrades, it is responsible for the release of ceramides and free fatty acids. So the calcium phosphate can reinforce the skin's barrier function, but also work with the acidity of the barrier function for increased infusion into the skin. There's no risk of any allergies with this. It simply degrades into a calcium and a phosphate ion, allowing for suitability for all skin types and conditions, but also durability and a time-release system that guarantees concentration of active ingredients within the skin. This final technology is not only a patented technology, but it's also Nobel Prize-winning technology. Although we call it telomere technology, the ingredient itself is called GGP, or geranyl lysopropanol. Telomere technology is extremely current and up to date. What we have is a repetitive nucleotide that's found at the end of chromosome strands. So to make this simple, it's a lot like a piece of string. When we're younger, our piece of string is 11 kilobases long, so it's long. When we get older, through multiple replications, the string becomes shorter, shorter, and shorter, and shorter. So we move from 11 to 4 kilobases in length. As the piece of string replicates and becomes shorter and shorter, it now begins to affect the transmission of DNA and now begins to promote, in essence, all the aging of cells and the tissue itself. So if you can preserve and prolong the string's length and then prevent its shortening as it begins to replicate, then we essentially have a preserving agent or a youth code for the skin that enables protection, that also enables preservation of the skin. With this technology, it is available in our most prestigious of the MG collection, which is called the MG Collection HA35+. So this serves as the most premium of products with the geranyl lysopropanol technology to now serve as a unique preservation system above and beyond traditional antioxidants and free radical scavengers. For all forms and types of hyperpigmentation, the MG Collection product that is specifically designed for rebalancing, rejuvenation, management, and also regulation is called the MG Collection Dermal, and this refers to bright light. There's been some recent updates for the EU, and this has allowed for new innovations with the BL. The BL now contains 3% tranexamic acid. This was previously just reserved for the prescription market. The role of a product that is to manage hyperpigmentation needs to intervene in all the melanin synthetic pathways. There is a system which I will cover in a little bit of detail tomorrow, but I encourage your research that's called Brendan and Gaviria. Melanin synthesis pathways. We're very familiar with our traditional tyrosine inhibitors. if you can sedate the tyrosinase response, which is a copper-containing catalytic enzyme, then you can slow down oxidation and formation of melanin. However, the melanogenesis story is more than just about tyrosinase inhibition. We understand, particularly through Renton and Bavaria's work, that there are 6 points of intervention, but one point they forgot that I'm going to add in is also going to be application and reapplication of sunscreen every single day. Renton and Bavaria look above and beyond just a tyrosinase inhibitor, which includes tranexamic acid, which also includes kojic acid dipalmitate, but looks at what's called a redox agent. The role of this is vitamin C in the form of sodium ascorbyl phosphate, but also looking at free radical scavengers, including copper peptides, which activate superoxide dismutase, but also the role of melanosome transfer inhibitors, which slow down the uptake of the pigment capsule from the melanocyte to the keratinocyte. This is the melanogenesis process here. Very quickly, it's a lot like building a house. The pituitary gland is like the cement foundation. The pituitary gland then sends a message to melanin-stimulating hormone, which becomes the wooden framework. Melanin-stimulating hormone then sends a message to tyrosinase, a copper-containing catalytic enzyme, which then creates a process of oxidation and instigation for melanin creation. So the tyrosinase is a lot like the bricks. So pituitary gland, cement foundation, melanin-stimulating hormone, your wooden framework, tyrosinase, your bricks. We then see oxidation of a free amino acid called tyrosin. If you've ever been in exposed ultraviolet light for a long period of time, and that process as your skin begins to darken and you begin to burn, that you notice it gets a very unique smell. That's the oxidation of tyrosin that you can physically smell. From tyrosin, the roof tiles, we then begin to see clusters of amino acids creating further bulk and oxidation and inflammation to create the pigment. This includes L-DOPA, which is a lot like the doors, and then L-dopa-quinone phosphates, which are like the windows. So this whole process, pituitary gland, cement foundation, melanin-stimulating hormone, wooden framework, tyrosinase, your bricks, tyrosin, your roof tiles, L-DOPA, your windows, L-dopa-quinone phosphates, which becomes your doors, now creates a whole structure. This house is your melanin. The melanin is produced within the melanocyte, and then the melanocyte signals with its dendrite arms, and then hands over the pigment capsule into the keratinocyte at the rate of around about 1 melanocyte to 36 keratinocytes. The whole role of this process here is now, particularly as we see with Renton and Bavaria, is how we can intervene these pathways. One of the most obvious is a tyrosinase inhibitor. So if you can prevent and sedate this process, you reduce the oxidation leading into tyrosin. This can be achieved through tranexamic acid, which will also reduce associated inflammation. So we understand that it's not just signaling that's coming through, it's inflammatory and oxidative information that's coming through. What we also get is to sedate the tyrosinase response, which now begins to reduce and prevent oxidation of tyrosin. As a redox agent, vitamin C fits into a new category to intervene for pigment formation. And the addition of the tranexamic acid allows for further precision work, particularly for melasma and particularly for dermal hyperpigmentation. We also see success with tranexamic acid for erythematous macular marks on the skin. So some people will pigment brown, some people following acne or trauma will pigment red. Tranexamic acid has the capability for both. We've also introduced a new ingredient into some of our home care products that is called soap or safflower seed oil, hypogonyl esters. This equals the effects of hydroquinone and a steroid, but without the complications and can be used easily longer term. The base MG collection products, including the BL for pigment and the CLR, this is a play on words for the English language, so I would sometimes call it clearer, as in clearer skin, but that doesn't translate well, so depending on the country, I would like to say clearer or CLR, but I'm referring to the same product. With this, they both contain 10 milligrams per milliliter of triple molecular weight polyfuse hyaluronic acid. So that enables a thick lubricating glide on the skin to facilitate the dermapen, but also facilitate as a delivery mechanism to deliver other ingredients into the skin. We spoke about acne before, that it's about infection, inflammation, but also retention hyperkeratosis, which is the fancy term for clogging and congestion. How do we target this at all levels? Firstly, you need a disinfecting agent that is specific for Cutibacterium acnes. What we have is a synthesized oligopeptide 10. When you kill Cutibacterium acnes, or previously known as Propionibacterium acnes, that then forces the reduction of Staphylococcus epidermidis. So this allows for bacterial balance. What we also allow with the oxygenation of Dermapen is a faster administration of the oligopeptide 10. Your second mission is to reduce inflammation. That can be achieved with tranexamic acid, but also niacinamide. The role of copper peptides is instrumental for production of superoxide dismutase, one of the most powerful antioxidants found within the skin. The next mission is to develop a process of microexfoliation and to re-establish regulated keratinization, but without physically burning the skin. So we've ingeniously used pyruvic acid as an effective corneolytic and keratolytic agent. So all of this now combined in targets all aspects of acne formation, infection, inflammation, but also post-inflammatory hyperpigmentation and congestion. So our oligopeptide 10 targets C. acnes bacteria, formerly known as the acnes bacteria, which then in turn reduces Staphylococcus epidermidis. The pyruvic acid that we have in the MG collection now becomes a more advanced method above and beyond salicylic acid for infusion and safe reduction of clogging and congestion. We reduce the inflammation with niacinamide, but what we also do is a very unique combination therapy with this is using tyrosinase inhibitors now reduces and removes the effects of post-inflammatory hyperpigmentation. So again, tranexamic acid, but also kojic acid dipalmitate as well. For collagen modulation, we understand since the research and development of medical grade retinoids by Albert Klickman, who's the father of modern dermatology. He's a little bit dead at the moment, but Klickman is the instigator of the use of medical retinoids, but also one of the pioneers for acne treatments. We understand the role of vitamin A is crucial for reversal, correction of any dysfunction within the skin or mutation. But if you're going to needle something into the skin, the form of vitamin A that you use is crucial. Because if you burn the skin, this is not a benefit. But if you use such a derivative that loses its activity, there's also no benefit. This is the role of retinaldehyde as a medical grade form of vitamin A. One conversion back into retinoic acid, but without the complications. What we're going to see in a moment is that the retinaldehyde equals the same reversal corrective effects as retinoic acid or prescription vitamin A, but without the complications. 0.1% does not sound very high, but this will enable some 200 to 400 times more power than cosmetic grade retinol. In addition to the retinaldehyde for collagen modulation, but also for establishing a better functioning extracellular matrix, we have the same base at 10 milligrams per milliliter of high diffuse hyaluronic acid, but blended in with copper peptides to activate superoxide dismutase and a pentapeptide 18. For further lutein, gluturicide, and Centella asiatica, but also the role of shiitake mushroom, which promotes a tyrosinase inhibition. Crady and Vienne are really the leaders and pioneers for retinaldehyde research and development. And what they were able to find is that retinaldehyde, like for like, the same percentage, delivers the same response and visual results of retexturization and revitalization as what prescription retinoic acid or tretinoin does. However, they also found that it was able to do all of this like for like without intolerance, without photosensitivity, reactivity, or having to build up your exposure to this ingredient. They also found that the retinaldehyde was able to effectively redensify the epidermis, redensify the dermis, again without having to build up the tolerance and the risk of retinoid reaction. As such, when we compare the two scales of medical grade vitamin A, we're at 0.1% of retinaldehyde, versus cosmetic grade vitamin A, such as retinol, which is typically capped at 1% across the world, you would need 20% retinol in order to get anywhere close to the effects of what 0.1% retinaldehyde can achieve. So with the mathematics, that means that retinaldehyde is 200 to 400 times stronger, which means it's 20 to 40 times more concentrated than cosmetic grade retinol. So the benefit of this is that you can achieve safety, predictability, and versatility via infusion into the skin, but without the reactivity, without having to build up tolerance, but to promote all aspects that a prescription vitamin A would provide. So in conjunction with Dermapen, with fibroblast growth factor, transforming growth factors, we now see a renovation physically of the extracellular matrix. So the MG collection RAS, or reversing aging and scars, is specific for aging, specific for any type of scar, specific for any type of striae, and skin rejuvenation we need to target down into the dermis and into the hypodermis. Due to the concentration, although there is no clinical evidence to support this, I would still recommend that either getting doctors go ahead before using this on a pregnant patient, or just avoiding it and substituting it with one of the other products. The MG collection HA35 is a revolution in concentration. So it features 35 milligrams per milliliter of triple molecular weighted patented hyalofused hyaluronic acid. So with this, it's 29 milligrams at the smallest molecular weight, which guarantees infusion down into reticular dermis, 3.5 milligrams of medium, 3.5 milligrams of large. This product will serve as a facilitator for PRP. It can be used to reconstitute botulinum toxin, but this can also be used to mix and match in any of your other MG collection products, such as the BL for pigment, the RAS for anti-aging and scars, or the Clearer, CLR, for acne, for you to up your presence of hyaluronic acid and for you to increase and to customize so that you can treat multiple concerns at the same time. It is inspired by our very first product we produced way back in 2012 called DpD Dermaceuticals Hyalactive. And as such, it also features zinc, but also contains panthenol provitamin B5. We've also added in vitamin C and a stabilized sodium ascorbyl phosphate. The benefit of this is that this is not filler. So it is non-cross-linked, no risk of granulomas. It does not contain DpD technology. This is the agent which cross-links the HA. So you have a biorevitalization as opposed to a physical static filling effect. This means that we work with skin texture, tone, quality, and health. The concentration with 29 milligrams per milliliter of small molecular weight means that you achieve penetration. Serves as a delivery system for other active ingredients. It's 175 milligrams per vial. So we're looking at high concentration, high activity. So when you mix and blend this in with your other MG collection products, it means that you can charge a more premium amount, but also it means that you can now start facilitating without filler, high strength, high concentration, 35 milligrams per milliliter of hyaluronic acid. So with this, if you want to create an increase of HA content for your MG collection BL for pigment, Clearer for acne, or RAS for collagen modulation, add in the HA35 and you up the hyaluronic acid content. What we also have within this product is the calphosome technology. So if you then further want to create ingredient stability, durability, longevity, and a time release system, you can also add it into your MG collection BL, Clearer, or RAS. This product will serve as your base glide for PRP procedures. So all you simply need to do is apply a very thin layer of the MG collection, HA35, onto the skin, and it will serve as a sticking agent. It will not dilute, it will not break down the PRP. Your PRP must be kept in an airtight syringe. So distribute a thin layer. Then you can squirt the PRP onto the skin, catch and distribute it with Dermapen, and then Dermapen it through. So you have this effective technique. What you can also do is use the MG collection HA35 as an advanced technique to now promote mesotox. So instead of reconstituting with saline, you would use the MG collection HA35. Botulinum toxin practitioners are used to working with units. This changes. If you're going to perform mesotox, you now work with milliliters. So with this, you would be looking at a region such as the nose for dilated pores, and you would be using, say, 1/4 to 1/2 milliliter of product to glide into the skin. So it's not exact like units. You may be using 1/4 of a milliliter for the under eye area. So you have versatility, new applications where the traditional anti-wrinkle injections don't work. The final product is the MG collection HA35. If in doubt, the MG Collection HA35 Plus will serve for every single skin condition that you will come across in clinic. Otherwise, this is also the most premium of the MG collection, which means the most expensive. So with this, not only do you have a base of 35 milligrams per milliliter of triple molecular weight hyaluronic acid, you also have the only product with the telomere technology, geranylgeranil lysopropanol at 0.1%. This also features retinaldehyde at the same concentration found in the MG collection RAS, which is 0.1%, plus calposome or calcium phosphate delivery mechanism. So combined in with vitamin A and vitamin E esters plus zinc, we have the most sophisticated complex. With this, you can use it as a sole MG collection, particularly for very volatile, rosacea, telangiectasia skin. But you can also blend this in with your classic MG collections to increase retinaldehyde, to increase your hyaluronic acid content, but to also increase your calposome or calcium phosphate content as well. You can blend it in with all other MG collection products for telomere or the geranylgeranil lysopropanol, but it can also be used by itself as an ultimate all-in-one mesoglide. By the term mesoglide, I refer to mesotherapy, but also a physical treatment glide that you use with Dermapen to now give you the best of autologous regenerative procedures with Dermapen, regulatory growth factors, collagen production, angiogenesis, elastin, but then physically feeding the skin with the MG collection. Your application is very, very simple. You've got options here. So firstly, you can apply it directly into a sterile basic dressing kit, or I suggest that you use a sterile container. This kit is the one that I referred to before. You can apply it directly onto skin. This would be an advantageous technique for your mesotox. This would also be an advantageous technique if you were using with PRP combinations. Otherwise, for needle psychology and for the theatre, you can draw this up with a Luer lock syringe, but bearing in mind that if you use a Luer lock syringe, you can also mix, blend, and customize. So you either want 5 cc's, 5 mils, or a 10 cc. The average face will probably only require about 3 cc's of product. So you can either give the remaining product to the patient to take home. This is not a retail range, so the patient cannot buy these from you. Or what you can do is pre-plan and draw up your syringes beforehand and mix and match prior to the patient. So this is being applied directly on the skin from the syringe. Once the lid is open, obviously it becomes from sterile to aseptic if you've not drawn it up. Then when you put the lid on, you still have 6 months worth of stability. However, what I suggest is if you know how many patients you have coming in over the next few weeks, what you may want to do is say, okay, I have at the moment 10 mils of solution, and I have, let's just make it easy, 5 patients coming in, which means 2 mils of solution. And with these patients, I'm going to be treating them for skin rejuvenation and scars. So what I'm going to do now is get myself 5 syringes and draw up 1 mil from each at the same time, cap the syringe, and then it does not need to be refrigerated, but then it means that you've still got sterile product and a sterile handling of your distribution and activation of your products. Otherwise, you can then recap and then give any remaining solution to the patient following the procedure to take home. And now we'll spend, and we're running a little bit ahead, but just the next few moments, probably about 20-25 minutes before we break for lunch. This is a lot of information today. Looking at the role of DpD pharmaceuticals as part of home care. The biggest challenge that we have within our market is, on one hand, that products are used to drive sales. And when products are used to drive sales, you have a jaded practitioner who doesn't want to be seen as selling. And then you have an over-treated patient who feels that they're being oversold to at every single opportunity, and it no longer becomes a therapeutic treatment, it's becoming just a sales experience. When I look at the role of DP dermaceuticals, I look at inspiration from the dentistry market. For the dentistry market, you need commitment to toothbrush, toothpaste, dental floss, and also your dentist. So, if I were to clean my teeth, toothbrush, toothpaste, dental floss, 20 times a day and never see a dentist for the rest of my life, there's a problem. If I were to see my dentist every week, but never clean my teeth for the rest of my life, there's a problem. So the role of DP dermaceuticals is like your toothbrush, toothpaste, and dental floss. Twice a day, every day, to direct, guide, balance, maintain, repair, and to repair post-op, specific for microneedling procedures. Yes, there are other ranges that exist within our market, but are they microneedling specific? No. The whole concept and philosophy of the DP dermaceuticals is exclusive, is formulated specifically for microneedling, which means that molecular weight, stability, acidity, concentration, everything has all been worked around for preparation and also for post-operative repair, regeneration, and protection of the skin. So, for all of your Dermapen procedures, it must be Dermapen World from start to finish with no substitutions. We're really smart at Dermapen World head office. When we get photos of complications, when we see issues with patients following or during treatment, we know when products have been substituted. We see all the telltale signs of substitution and of the wrong products, the wrong ingredients, the wrong formulation being applied to the patient's skin. This is why you need a range that is specific, that will enable predictability, reliability, but most importantly, safety for practitioner and safety for the patient. So I call this the non-negotiables. The range delivers everything that you would require for the skin indications that you're treating with Dermapen. The first product is called Tri-Phase Cleanser. Quite simply, you're not paid enough to remove 20 coats of waterproof mascara and 25 coats of transfer-resistant makeup. So patients know when they're coming in to see you. They've known for 2 months that they've had that talking, and when they come in with such heavy makeup, it's disrespectful, to the point that it takes you 10 minutes to have to remove all of that for a 3-minute procedure. So the Tri-Phase Cleanser is the ultimate treatment that will counterbalance, counteract anything heavy, waterproof, transfer-resistant makeup to remove it in one step, one go, every single time. It applies as a balm, it then emulsifies into a gel, add water, it removes as a milk, no toner or no second coat required. This is the ultimate in clinic to remove everything. But its design is also the ultimate non-negotiable for post-operative care. For home care, we do produce a foaming cleanser, which is called the Clear Up Foaming Cleanser, a unique combination of salicylic acid in a botanical form, Manuka honey, which is a medical grade honey that will reduce inflammation, but also at a pH of 7.2, it will not strip or irritate the skin. It can also be used as a shaving medium. We do also produce a mechanical exfoliant that utilizes micronized bamboo particles, but also lactic acid in the form of microderm exfoliant. excuse me, all of these products are available in large in-clinic sizes, which is a 250 ml aseptic airless pump. And then, of course, they're available in retail sizes as well. A non-negotiable for your treatments is called ClinPrep. The ClinPrep solution is a combination of hypochlorous and phosphoric acid. We spoke in detail earlier about the role of the macrophage. The macrophage undergoes a process called phagocytosis, where it then begins to process pathogens. How does it process a pathogen? It releases hypochlorous and it releases phosphoric acid, which means that if you replicate this technology in a water base, it means that you can't be allergic to it. There's no irritation, even with eyes open. It can be used absolutely anywhere. But also, like your macrophage, it's antibacterial, antimicrobial, antifungal, antiviral, and anti-spore within 15 seconds exposure time. So by contrast to alcohol, which is antibacterial and very basic, by contrast to chlorhexidine solution or iodine, which will require very long exposure times, up to a couple of minutes, all of this can be achieved in 15 seconds and used absolutely everywhere in a water base. There's no stripping, there's no irritation, but you have safety and efficacy for at-home care, particularly for acne, particularly for papulopustular rosacea, for post-operative care, but also it's available in a big 500 ml pump that can be used for disinfection of everything. So you can use that for every single procedure that you are currently performing for effective broad-spectrum antibacterial, antimicrobial, antifungal, antiviral, and anti-spore. From our cleansing and disinfection, we now move into two categories of corrective products. The first is a water base, which is a penetrating serum. And then over the top, there is an emulsion corrector. There's versatility with the products that means that you cannot make a mistake. So this means that you're not going to have any reactivity if you prescribe something that would be more suitable for anti-aging for a patient with rosacea. So the concept is a biostimulation and a biorevitalization. All corrective products still use a base of the high diffuse hyaluronic acid. So this allows for increased product penetration, but stability within the skin. The very first product we produced is the Hyalactive. It's a base of 10 milligrams per milliliter of triple molecular weight hyaluronic acid, plus zinc, plus panthenol or provitamin B5. This is an hydrating corrector, penetrating serum that can be used by every single skin. But it's particularly advantageous to be applied following cleansing for severely dehydrated, compromised skins, for post-operative skins, irrelevant of what the procedure was. So this can be used following fibroblasting, this can be used following injectables, following ablative laser, even following semi-surgical procedures. With this, it will serve to increase hydration, protection. I just realized that the bottom line here is incorrect, just ignore that. And you have versatility for all skins, particularly for rosacea, particularly also for anti-aging, but also for pigmentation. The other choice for your water-based corrector would be the antioxidant cocktail. This is a blend of vitamin C in the form of magnesium ascorbyl phosphate, niacinamide to reduce the inflammation, but niacinamide is also a very potent melanosome transfer inhibitor, which means it slows down the exchange and the relationship between the melanocyte and the keratinocyte. With rooibos and peptides, you then have a very anti-inflammatory formula. So Hyalactive to sensitize post-op volatile skins, but particularly for anti-aging, pigmented, and for rosacea, I recommend the antioxidant cocktail first. Over the top of your water-based penetrating agent, you will then use an emulsion corrector. So the emulsion correctors are thicker in size. For all pigmentation, I recommend the bright light. It is a blend of tranexamic acid, kojic acid dipalmitate, vitamin C, licorice. This can be used anywhere on face and body for any type of hyperpigmentation. I would recommend best to apply over the top of the antioxidant cocktail in the morning, and then at night time for pigmentation to use the retinol active over the top of the antioxidant cocktail at night time. The retinol active, as the name states, is retinal. Retinal is the abbreviated form of retinaldehyde. So it's not a spelling mistake. Retinal is not the same as retinol with a spelling mistake. So as retinaldehyde, it's at 0.05% concentration, so half the amount that you find in the MG collection. But with a blend of copper peptides and neem, which will also serve for treatment of acne, with very versatile retinoid that can be used by all skins. It can even be tolerated by a rosacea-prone skin. So I recommend still at nighttime, although retinaldehyde is not photosensitive, that you can apply over the top of your highlight active or over the top of your antioxidant cocktail. For post-operative care as a dual corrector, but also as a dual moisturizer in one, there is DpD Dermaceuticals vitamin-rich repair. It works on vitamin A esters, which now enable a slow release repair response, but in conjunction with highly antioxidant resveratrol and copper peptides, promote a process of rapid repair. So post-op, you would be using Tri-Phase Cleanser, vitamin-rich repair, and then your sunscreen, which is your cover recover on top of the skin. And that is your non-negotiable for at least 4 to 5 days following your procedure. But otherwise, for a severely aged, environmentally damaged skin, you could use antioxidant cocktail in the morning with vitamin-rich repair over the top during the day, and then at night, antioxidant cocktail followed by retinol active over the top. So you always put one of your emulsions over the top of your 2 water bases. Another dual product is called Clearer Lotion. The Clearer Lotion is a corrector, but also a moisturizer that is designed for seborrheic, so excess oil, or for acne skins. It's a blend of the same oligopeptide 10 that you see in the MG collection, plus manuka honey and niacinamide to reduce the associated inflammation. And it uses salicylic acid at 2% for exfoliation. By contrast, the MG collection, Clearer, utilizes pyruvic acid. So the CLR lotion fits into both categories as either being a corrector and a moisturizer, but also being a moisturizer itself. So with this for an acneic skin, you've got the simplicity of cleansing with Clearer foam cleanser. They can disinfect with the Clinic Prep, and then correct, repair, heal, and exfoliate with the Clearer lotion. Otherwise, for normal to dry and dry to very dry, they can use the skin veneer. The skin veneer replicates the skin's acid mantle 100%. So with this, the skin's acid mantle is a very unique combination. I draw this up purely for your interest. So we have our follicle. Inside the follicle, inside the sebaceous gland, you have sebocytes. And sebocytes are responsible for production of sebum. Sebum is a combination of 57% triglycerides. That is a base oil, so olive oil is a triglyceride. You then have 25% wax esters. A wax is still an emollient. It's still a lipid, but it's just not chemically a base oil or triglyceride. You then have 15% squalane, again, another type of lipid. 2% cholesterol, and 1% cholesterol esters. That's sebum. Then in the skin, in stratum granulosum, you have the release of what's called a lamellar granule, which is also known as a keratonosome. That secretes ceramides and free fatty acids. The sebaceous gland, as part of its own process to fight free radicals, also produces vitamin E. So the combination of sebum, 57% triglycerides, 25% lactic esters, 15% squalane, 2% cholesterol, 1% cholesterol esters, plus vitamin E, plus ceramides and free fatty acids produced by your lamellar granule equals your lipid component of your skin's barrier function. Now you're going to have what's called natural moisture factor. So natural moisture factor is unique because it's your water binding capability, but there's actually no water in it. So it's a lot like jelly crystals. You need to activate it in order for it to serve its full potential. Can I wipe this away? So I draw this up to understand the chemistry and the effect of both Dermapen, but also the role of your DpD dermaceuticals as a synergistic effect. Natural moisture factor is about 40 to 42% free amino acids. So an amino acid is a base building block. If you have a chain that is 50 or less, we call that collection of peptide. If your chain is 50 or more, we call that a protein. So when large proteins like keratin break down or collagen break down, your individual building blocks are free amino acids. What we also see is around about 22% salts and sugars. These are like the electrolytes within the skin, so you take into account sodium, magnesium, but also calcium, all as potent water binders. You have about 15% hyaluronic acid sitting within the skin. You have about 11% lactic acid. This is the reason why lactic acid is more hydrating than glycolic, because it naturally sits as part of your skin's natural moisture factor. Then we start moving into other ingredients, such as sodium PCA. The PCA stands for pyroglutamic acid. So technically, it should be PGA, but they call it PCA. Then you have urea, and then uricanic acid. Activate your jelly crystals with water, then emulsify that into your lipid phase, and the emulsifying agent are the cholesterol and the cholesterol esters that you find. This creates your skin's barrier function. So the reason why I draw this up is because if you can replicate this 100%, you then get skin veneer. So the skin veneer is designed to replicate the skin's barrier function. So irrelevant of whether it's normal, sensitive, super dry, not so dry, combination, mixed, whatever that may be, you have perfect replication. So that creates the perfect balance and drip feed customization for every type of skin. For scarred skins, we produce a very specific silicon base, which is called scar. There are 7 types of re-epithelializing silicons, plus zinc, plus also to reduce the signs of post-inflammatory hyperpigmentation. There is the soap, which is sapphire seed oil hyperonal esters. And this will equal the effects of a hydroquinone plus a steroid without the irritation. I recommend this for all types of scars, new or old. So for scar protocols, I would recommend use your corrector as retinol active and then your scar cream over the top. We do also produce a retinoid-based eye corrective product. That is the RER eye serum. Simply depress the button and it will release the product onto the roller ball. Not only does it feature retinaldehyde, but it also features a very up-to-date ingredient, which is a botanical retinoid called bakuchiol. It recreates all the benefits of retinol, but without the irritation or photosensitivity, particularly around the eye contour. So plus caffeine and plus probiotics, you can treat and target dark circles, anti-aging, but also fatigue around the eye area. Finally, the products that we can explore include Cover Recover. I've introduced this previously, but the Cover Recover is a broad spectrum SPF 30, which is PA++, which means that it is against UVA, UVB, and also the very minuscule amounts of UVC. The base is 3 types of silicone. Silicone often gets a very, very bad reputation in our industry, and very incorrectly so. What the silicone does not absorb. It sits exactly on the skin's surface, allowing for a protective re-epithelializing layer. So if you need the evidence for silicone, there's what's called the kinetogenicity test, or the rabbit ear assay, which was performed by Fulton and Kligman. Fulton's a little bit dead at the moment now. Fulton and Kligman, Kligman's the father of modern dermatology. Fulton and Kligman were the world leading experts with acne. You might know with Fulton, he was based in Florida. With Fulton and Kligman, it is called commonly the kinetogenicity test. It's performed about 3 times, but what they do is essentially rate the risk of irritation, but also the rate of how an ingredient can clog and congest the skin. The evidence is here. You don't argue with these 2 pioneers of dermatology. Silicone cannot clog and irritate your skin. Sunscreen cannot clog or irritate your skin either. The Cover Recover also contains a probiotic, which will treat and target any bacterial imbalance on the skin. And you also have a thermoregulator, which removes any heat out of the skin. So you'll love to use the Cover Recover following any procedure. So any procedure where you need to re-epithelialize, any procedure where you want some coverage. The coverage itself is an iron oxide. The sunscreen protective agent is a zinc oxide and titanium dioxide. With this, it's available in 9 colors that will suit all Fitzpatrick skin types and ethnicities. It's also available in a sheer, which is a lower payoff, so less pigment intensity. It will color adapt. And then there's also a clear, which will work for any body work that you do. You can sleep in it even after your treatment. We produce post-operative masks, which can also be used at home. I haven't put these ones on the screen, but if you were working with LED, you will not be able to use these masks. Because they're in a cloth base, the light will not penetrate. We do produce what's called LumiFuse hydrogel masks, of which can be applied, and LED can be applied over the top. So a red light or a near infrared. Do not use the cloth ones with LED because nothing will happen. But otherwise, the highly active 3D sculptured masks are all based on a blend of zinc, sodium, manganese, iron, and copper ferments, plus copper peptides. The original formula comes in a version for the face. The cloth mask will wrap around the ears. You will use this immediately post-op. But the face version also features in the neck and décolleté, and also in a hand mask. We also produce the mask in a bright light version, which is just for the face, that has the addition of kojic acid dipalmitate and superoxide dismutase. And then we also produce specifically for the eye area, the RER or Rapid Eye Restore. The addition of eshin or horse chestnut will accelerate microexfoliation. The addition also of caffeine and a peptide complex works with puffiness and all signs of fatigue in the eye area. To do some summaries before we take a break for lunch. Just as you need to follow the rules after you've had a surgical procedure or after you've seen your doctor and something is wrong and you've been given a prescription, just as you need to follow that exactly, it is no different with a Dermapen procedure. Your post-op prescription is the same for every single patient. And what our post-op non-negotiables are is tri-phase cleanser. Can I use a different cleanser? No. Did you use a different cleanser? No, I think you did, because look at these photos. Look at your skin. We know when you substitute. Likewise also, the vitamin-rich repair morning and night as a dual corrector, but moisture protective that will not trap heat, and to be applied multiple times a day, the Cover Recover. The Cover Recover following your procedure, you can actually leave it on. They don't need to wash it off that night. So I suggest that they put on another layer in the afternoon, and then the next morning, wash, tri-phase cleanser. If you need to, or if your patient has more money, this is not a problem. You could then disinfect. This is particularly important for very high humid parts of the world, Southeast Asia, for example. Hyperactive can be used for increased hydration, particularly if you're going to use a combination therapy, the skin feels a little bit tight. But otherwise, your 3 minimum, so I'll always give you your 3 minimum to make it affordable for the patient, but then you can add in tri-phase, vitamin-rich repair, Cover Recover. We produce all of these in starter kits, so my suggestion is for a Dermapen procedure, whilst you will see a result after 1 treatment, you're still looking at a minimum of 3 to 5 procedures for longevity. It needs to be a course of treatment. So why not incorporate the cost of one of the starter kits, which contains everything that they need, into that program, which then means you can guarantee the patient is using the right products. Have a look at protocols which we will explore further after lunch. We always cleanse the skin with tri-phase cleanser. That removes all makeup. I notice on social media that many practitioners, and I do write to them, start filming their patient, or the patients filming themselves with a full face of eye makeup and lipstick as they're being Dermapen. Bad decision. Just as you can infuse your MG collection into the skin, if you have pigment from mascara, eyeliner, and lipstick, you will tattoo it into the skin. So you must remove everything. Tri-phase cleanser will do that. If you then wish to create a more spa approach, which is not a problem, you can then use the microdermal exfoliant for a very light exfoliation and retexturization of the skin. Work out what you need to be treating. Take photos. These are the most powerful thing that you can do. We do produce a CBD range, which I'm not going into detail so much today, but it does produce an elixir in a 500 and 1000 milligrams. The CBD or cannabidiol is THC free, so it's non-psychoactive, but when applied topically, it actually serves as an analgesic. So by contrast to an anesthetic, which prevents your experience of nerve sensation, an analgesic changes your experience and perception of that nerve sensation. But otherwise, as we've discussed before, this is not necessary for most procedures. Set up your treatment kits, set up your set. We're going to disinfect the skin based on your experience, based on the indication that you're treating and what you think you're going to need. No blood pink skin, no blood red skin, occasional pinpoint blood, consistent pinpoint blood or consistent moderate blood. You're then going to determine what your depths might be. Divide the face up. It doesn't matter what your order is, so long as you're aware that you are changing your depth for each region. Your mesoglide, then we will Dermapen. Post-op for a standard treatment always concludes in the same way. Post-operative hyperactive masks, these are never to be substituted. The design of these with small molecular weight hyaluronic acid continue on the mesotherapy process, but also reduce the visible signs of erythema and edema. Once the mask has been removed, vitamin-rich repair, and then the cover recover, which can remain on overnight, and the patient can wash it the next day. So before we break for lunch, I'm going to show you the treatment in action. This is the tri-phase cleanser, and you'll notice the size of the bottle is what the clinic sizes look like as aseptic 250 milliliters. It applies as a relatively rich balm, but that will quickly emulsify to a gel. So that means it will remove the bulk of thick, heavy, waterproof makeup. You then add water and it turns into a milk phase. That will remove with no residue, which means you don't need to tone. You can then perform, particularly if you're moving into a more holistic approach, so this is optional, a light exfoliation. You'll have many practitioners say, can I do a microdermabrasion now? Can I do a chemical peel now? And you say, well, why? Well, because if I get rid of all the dead skin cells, it means that the Dermapen is going to penetrate more easy. We're not talking 2 millimeters of dead skin cells. We're not talking 3 millimeters of dead skin cells. We're talking microns, tiny. So with this is an extra step, but it's not necessary. And it's not going to make your procedure work any more effectively because the needles are already penetrating. As an holistic approach, and this is where I'll introduce some of the CBD range, we understand that the CBD, which is in caprylol triglyceride, which is a fractionated coconut oil derivative, which means it will not clog or congest. What this will do is enable penetration of cannabidiol. The cannabidiol, or CBD, which is extracted from the cannabis plant as a cannabinoid, is THC-free, so it means that the psychoactive part is being removed. The concentration of this and where we see support in studies is that the CBD is not only analgesic, but it's exceptionally anti-inflammatory. It promotes wound healing. It is suitable for all skins with absolutely no challenges. But if we use the little roller ball on the needle cartridge here, we can create vibration therapy, which reduces the nerve sensitivity, but also the analgesic effects of the CBD now allow for increased comfort, particularly if you're going in at a deeper depth. Or this promotes a more holistic approach, particularly if it's the patient's first time. So I'll share with you ways that you can do Dermapen in 20 minutes, 3 patients an hour, more profitable than fillers, but I'll also show you ways that you can turn this into 45-minute, 60-minute, hour-and-a-half treatment by adding and combining new combination therapies. Remove any excess residue and disinfect with the Clinic Rep solution. This is what the 500 ml of the solution looks like. It needs to be left on the skin for at least 15 seconds. I also recommend with this that you don't rub it into the skin because it will deactivate the hypochlorous. And now we have our perfect preparation for the skin. I'm going to share with you, I'll go back. I'm going to share with you the actual steps, next steps of the procedure itself after lunch break. And then we're going to explore how to now take it into new territory with combination therapies. We're going to introduce you to anabolic chemical healing, which is very different to your normal concept of healing, where you're used to removing and taking something away. This is a lot more similar to, say, mesotherapy to promote a process of rebuilding, and then we will move into our practical demonstration. So I've got it exactly as 1:30. We have a little over an hour for lunch. Lunch is going to be held across the road down the street at the Avalon. And so if we can be back at 2:35, exactly on the dot. We're running a little bit early, so we'll finish up a little bit earlier because we've got a smaller crowd. But any thoughts, any questions or anything like that, keep that in your mind so that we can also go into discussion mode as well. Make sure you eat lots and have lots of caffeine. Okay, so we've set up our treatment parameters based on if you need a speedy procedure or if you need to extend that out with a more holistic approach. So our options for our holistic approach are going to include the microdermal exfoliant, but then also the massage with the CBD elixir. Depending on your local laws, you'll need to check this out. It is possible to take CBD elixir sublingually, so a few drops underneath the tongue. There is no problems. It is non-psychoactive, THC free, so the patient can drive home. There's no issue with that, but it will promote a sensation of well-being as well as being applied topically to the skin and massaged through. So we want to remove any residue of any topical local anesthetic, if you're using that, of any CBD elixir. I recommend the CliniPrep solution. This will serve as your saline, as your toning lotion, as your easy clean lotion if something gets in the eye, into the mouth, into the nose, if you need to neutralize something. So it comes in both a spray and in a pump. I find it easiest if you dispense the pump into the spray and use the spray because it's quick, it's fast, it's easy. Remember 15 seconds exposure time, and because of the hypochlorous solution, don't sit there rubbing it into the skin. Now the skin is clean. We have our preparation for our MG collection. As we've explored before, we've got 4 options, either straight into a sterile basic dressing kit. I prefer the theatre, but I also prefer what separates a Dermapen procedure by comparison to another microneedling procedure is the attention to detail for this. For PRP or for botulinum toxin, directly onto the skin, but otherwise, for needle psychology, if the patient needs to see this theatre, or if you're going to mix, match, and blend your MG collections together, use either a 5cc or a 10cc Lillock syringe. For this process, you will probably only require about 3 to 4 cc's for a full face, neck, and chest. So why not use that time? If a full face is going to take you about 3 to 5 minutes, then the neck is an extra minute, and moving on to other areas such as the backs of the hands also is very, very quick. That now means that you can charge a higher amount. It's more profitable. You're still using the same amount of product, but instead of giving it to the patient to take home, you're using it in clinic over more areas. This is the procedure itself for a standard treatment. I choose to start with the forehead because traditionally it's the most uncomfortable. Because it's bonier, because the skin has less density, it is more sensitive. If it's out of the way first, then everything else is going to be easy. Apply your MG collection, working away from the eyebrows. If you try to work downwards, you're going to find that you end up with an eyebrow in your eye socket here. If you work upwards, it naturally supports the skin. So I'm trying to avoid practitioners having needles in between their fingers and having a needle stick injury, but also getting the patient to do all the gymnastics and the support work for you means that you don't need a third hand, or traditionally for the medical environment, you don't need a nurse to also sit in on the procedure. So if you work for the forehead from bottom up, it naturally supports the skin. For the cheek area, the beauty market always says work up because it's going to lift the skin. No, it won't. Gravity kicks in. But if you work downwards, it'll support the skin so that your device is not caught under the cheeks or under the jawline. If you also work from inside out, it means that you're not having to hold and support the skin or work between your fingers. For areas such as the neck, if the patient does all the stretching for you, you have a nice, flat, even area. So as the patient moves their head around for the chin and jawline here, the same process of vertical, horizontal, diagonal 1, diagonal 2, they do all the support. If you work up, you're going to get caught with the bottom lip. You're going to get solution in their nose. It's not comfortable. So with this process here, for me, the average patient can tolerate the chin and jawline very, very comfortably. So moving from the forehead, then to the chin and jawline is a nice relief for them. This is a superficial procedure. So again, as we spoke before, where nerve receptors are sitting, the patient will feel a vibration, the patient will experience a sensation, but not physical pain. For the cheek area, you will need to increase your density. So I want you to imagine with the orbital bone here that it goes and extends right out to the ear. And then the side of the mouth here extends to the lower part of the ear. So you have this big square section here to treat. Same process of vertical, horizontal, diagonal 1, diagonal 2. If you're not achieving your desired visual response, you have a few options. Either increase or decrease your needle depth and repeat. Or if you need to add more rejuvenation, you can do a multi-pass, which means needles in, strike, 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 needles out. Needles in, strike, strike, strike. So there's no wrong or no right, but it's understanding why you're doing what you're doing. So essentially whatever gets you to that correct visual endpoint. If you then need to go further for mechanical rejuvenation, then use your imprint technique. The ice is unique because not only are you going to target the lower eye area, but you're also going to target through the tear troughs themselves and also on the eyelids themselves. This is going to be highly unusual for the patient because number one, they're not used to this. Number two, we think it's going to be very painful. It's not. It is the strangest vibration. You can feel your eyeball vibrating. And number three, you are treating and targeting areas where you're not using any chemical peel, where there's no laser, there's no IPL, you're not using or treating any injectables, no fillers through this area that you can treat comfortably. Note that this patient has tattooed eyebrows. You will need to be careful of over-treating over cosmetic tattooing. Cosmetic tattooing fits and sits around about basal epidermis, epidermal junction. So if you are over-treating over areas, then you're going to find that you can fade the pigment. The nose is a unique area purely because every shape is going to be different. So whatever gets you as possible, a vertical, horizontal, diagonal 1, diagonal 2. We conclude with the upper lip, which is traditionally the most uncomfortable area. So immediately straight over your post-op new skin, we're going to apply one of your hyperactive 3D sculptured masks. So you'll notice even at this point that there's no blood coming out, there's no serum coming out. The average patient's puncture channels will remain open for around about 3 to 4 minutes. Tomorrow when I talk about the PRP topic, we're going to be finding some studies from perhaps the godfather of PRP, Gordon Sasaki, based in the US, where he's shown that the platelets will still actually deliver and travel through those closed puncture channels 2 to 3 hours after the actual procedure. But for our standard procedure, the hyperactive 3D mask, it hooks behind the ears as a cloth mask, zinc, sodium, manganese, iron, and copper ferments, copper peptides, panthenol. Realistically for this, because your puncture channels are in the process of closing, for the abnormal patient, it may take up to 7 minutes. If you're in a fast medical clinic and you want a patient in and out every 20 minutes, 3 patients with Dermapen and an hour, which will rival your profitability, say for botulinum toxin and filler, you probably want to leave this on for 5 minutes for 7 minutes. But for an holistic approach in a clinic, if you want a more spa effect or more well-being or relaxation, this can be left on, I would say 15 minutes. It will still remain moist for up to 45 minutes. So then you can start incorporating other combination therapies, whether that's massage or whatever that's going to be. Remove the mask. The cloth will remove any dried up residue. If you need to re-disinfect, not a problem. You can never over-disinfect with the Cliniprep. If there's any MG collection that's remaining, my suggestion is that you apply a few drops onto the patient's skin, press, don't massage over freshly needled skin, and give the remaining solution to them if you haven't pre-planned and drawn up your syringes. We always conclude with vitamin-rich repair. This is the 250 ml aseptic clinic size, and then this is the cover recover shear. This is the only one that comes in a bulk size. This is what the retail sizes look like. But the shear, particularly for the demographic for Ireland, should color match and adjust for 80% of your patients. Treatment over. So all in all, when you see how fast the physical procedure can be, you can see how profitable it can become. But you can also see that microneedling is not 1990s style of blood, aggression, trauma, and pain. So it's very tolerable. And so Dermapen treatment really separates itself from other devices because of its speed. Speed equals comfort. So when you hear that noise of Dermapen 4, that comfort equals better infusion, and that also equals a more positive treatment experience. Now what I want to do is to talk about further ways to deliver a combination therapy. We produce 2 microneedling compatible chemical peels, but rather than associating them with your traditional understanding of what a chemical peel is, which is a resurfacing agent designed to remove something, I want to focus on the anabolic capabilities, which means promoting a process of rebuilding. There are 2 peels. One is called Uber Pro, the other one is called Uber MD. I'm only going to touch on the Uber Pro today, not the MD. So, the Uber Pro is an anabolic chemical peel that is designed for application immediately following your Dermapen procedure. Not before, but following. You're going to have practitioners ask you, you're going to have patients ask you, why are you doing this after Dermapen? Shouldn't you exfoliate first? Number 1, practitioners for some reason believe that there's like 4 millimeters of dead skin sitting on your face and you must remove that so that your Dermapen needles can penetrate the skin. Not at all. We don't have that much thickened dead skin. It's not like treating the back of someone's feet with this. Number 2, we also understand that this peel is not like your traditional resurfacing agent. So a traditional peel is designed to activate a controlled chemical trauma. The controlled chemical trauma then creates a removal of skin, depending on whether that is very superficial, medium, and then in medical cases that can go to deep. The Uber Pro anabolically is more likened to mesotherapy than what it is to traditional resurfacing peels. So it activates a process of repair, of rebuilding, but depending on which indication that you're also treating, that can be from tyrosinase inhibition to stimulation for collagen modulation, but also at the same time for disinfection and acceleration of retention hyperkeratosis, so treatment for acne. So the concept is to deliver a combination therapy that maximizes your puncture channels whilst they are in the process of closing. That means that the peel is fractional because it's not actually burning through the epidermis to get to its end point. It's using the puncture channels to get to its end point. So for example, epidermis, basal spinosum, granulosum, receiving corneum. Let's look at a standard superficial medium depth peel. In order to get to granulosum, you have to remove everything to burn that through. How you've done that is day 2, day 3, it starts to tighten, and then you get this flaking come through. But with Dermapen, with 1,920 puncture channels per second, we're actually using these puncture channels to drizzle the peel down. So it means that the peel itself is fractional, and just like your Dermapen, it means that your epidermis physically remains intact. So even with the Uber Pro, there is no flaking or shedding of the skin. The design of the peel means that there's no extra downtime. So you don't have any tightness, you're not going to have any extra redness or any extra days or commitment to having to hide away from public. The advantage is for the peel is really depending on the needle depth that you use will then determine as to where the peel goes. Molecularly, the peel as an individual product is a superficial. So that means that if you were to apply it on intact skin, multiple coats, it could travel down to granulosum. But if you're using it with Dermapen, which is the key aim of this peel, then this means that you can drizzle that down further. But particularly, the key focus is going to be acne, but also hyperpigmentation. So you can see that this is advantageous for basal, which is where your melanocyte is residing. And then the exchange with the keratinocyte is spinosum. The only thing that changes for your pigmentation is when you need to target the pigment containing melanophage, which is seen in very superficial papillary dermis. From this, what about the treatment of acne? I find very fascinating across the international markets advertising on televisions for acne creams or acne gels for teenagers, because the ads always look like this. They draw a follicle like this, and then the follicle has dirt, congestion, and all of this through it. And then the teenager applies their miracle acne gel, which then comes in and completely cleans out the follicle, and then all of the dirt and grime is completely gone. That's impossible. If we were to draw this up precisely, this is epidermis, that's dermis, that's hypodermis, and you have major blood supply coming through this area. So if that's how acne and clogging and congestion really was, you would be bleeding and burning every single time you applied your acne gel. So when we have a look at acne formation, that's okay to remove this. It's actually the other direction. So we call it retention hyperkeratosis. So it means that your clogging and your congestion, that's a very bad follicle, but work with me, is actually working from the top down into the follicle. So you need to remove a plug. You don't need to remove residue at the base here. So again, if we start looking at this closely, you can see that that plug is localized to the epidermis. This is why your acne procedures aren't targeting all the way down into the dermis. This is why you don't need blood. Notice though that if you do have, I'm just in diversion mode for a moment, if you do have an active papule nodular cyst and you Dermapen over the top, of course it's going to bleed. You'll have some localized blood, but so long as the entire face is not completely covered in consistent moderate blood, then you're working in the right level. Back onto the peel though. The challenge with peels from a cosmetic chemistry perspective, and particularly when we've explored the ingenuity of the MG collection, Dermapen is one thing, but cosmetic chemistry and innovation for the products that you're using to go into the skin is a huge area of development, study, research for this. If your cosmetic chemistry does not support the procedure that you're doing, it's instant problems for this. So when I look at the cosmetic chemistry for anabolic peeling, such as Uber, there's challenges with peels and formulation. You'll notice that most peels on the market are normally a monotherapy. So this means that you have either an individual alpha hydroxy acid, lactic or glycolic or malic, or you combine a complex of alpha hydroxy acids, but very rarely do you see an alpha hydroxy acid combined in with an aromatic alpha hydroxy acid, mandelic acid, or combined in with a phenolic acid compound, which is salicylic acid. why don't these all work? Your water bases and your oil solubles, from a formulation perspective, don't particularly like each other. So mandelic acid and aromatic alpha hydroxy acid is oil soluble. You then have salicylic acid. So sorry to bust on this, salicylic acid has not been a beta hydroxy acid for decades now. It actually fits into a category that's called a phenolic aromatic compound. But salicylic acid is also oil soluble. So when you combine your water solubles and your oil solubles, it's very, very difficult to get stability for your formula. If you get the formula right, it might last in the bottle for about a week, and then just normal oxidation and time changes the pH, and your product no longer works in around about a month or 2 months' time. So that's problematic. The other issue is that for an alpha hydroxy acid, for a phenolic aromatic acid, or for an aromatic alpha hydroxy acid, they need to be an acid, which means that ideally you're looking at a lower pH, generally underneath 3.5. When you then want to combine in a retinoid, retinoids or vitamin A's work better at a higher pH. So from a formulation perspective, you're looking at around about 7. So if you put 7 with a pH of 3.5, whichever one's more dominant is going to neutralize the other one out. So the challenge of putting a retinoid into a blend of water solubles and a blend of oil solubles is incredibly difficult to do. And if you can do it, to then get stability that will give you a stabilized formula that lasts over a week is going to be very, very hard to do. It's not uncommon to see some blends of acids out on the market, but the product's only going to be valuable for 1 month and you need to keep it in the fridge. And it's all because of the changes of pH, which ends up neutralizing itself out. So what we have is called a peel emulsion innovation. This means that we are able to stabilize and secure the water solubles, plus the oil solubles, then introduce a retinoid into it, but still keep it at an acidic pH and keep it stabilized. The combination that we use is called dimethyl isosorbide, which is a stabilizing and emulsifying agent. The other ingredient that we have is called resorcinol. Resorcinol is an older peeling mechanism. So resorcinol can form part of traditional jesna peels, and resorcinol can also be at 20%, 30%, can also be its own peeling agent. However, there's not enough resorcinol within this product in order for it to be a resurfacing agent. So despite the fact that it's written on the packaging, despite the fact that someone will look at the back of the box and say, hold on, this is a resorcinol peel, it's not a resorcinol peel. The resorcinol serves as an emulsifying agent to bind the water and the oil-soluble agents, and then the dimethyl isosorbide then works to introduce the retinoid, which is retinaldehyde in this case, to then enable stability, blend, and complex, which is all at a pH of 2.05. Because the peel is working more similarly to a mesotherapy, and because of the design of it, you can't burn anyone. I've yet to see anyone burn with the entire international market. You should never see frosting. You should never see any whitening or blanching of the peel. It is that predictable. So you can use it on all Fitzpatrick skin types and all ethnicities, from the fairest to the lightest. With this, furthermore, it's fractional, so it's using the puncture channels to physically drizzle the peel through. The aim of it, with its stabilizing emulsion formula, means that it only needs to be on the skin for about 30 seconds to about 3 minutes. It does technically self-neutralize. So if you have a moment that you weren't paying attention, or if you leave the room, nothing bad's going to happen. But with this, it's extremely predictable. The peeling itself is more restricted superficially. So for the skin, even with your puncture channels, the design of the molecular weighting means that it's going to tend to hang down to about basal epidermis, but through a fractional delivery. This is the reason why you don't get frosting. So frosting or blanching is coagulation of the keratin protein. And with this can be achieved with the UberMD, the medical version, which I'll cover tomorrow. But for this one, I've never seen it. We've tried to do it on purpose. It just won't happen. But this is not encouraging you to do so. For treatment versatility, the design of it is going to be most advantageous for hyperpigmentation, including volatile melasma, for acne, stage 1, 2, and 3. You can also use it for a superficial refresh of the skin. The peel will not give you any result for scars. It won't give you any result for deep wrinkles. It's not going to give you any result for stretch marks. The ingredient blend, but also the design and how deep it goes, will not give you that response. So following my Dermapen procedure, the peel, this is what your skin looks like. So for about 7 seconds, the patient's going to feel a tiny bit of lukewarmth. So normally when someone says lukewarmth in a training, that means it's boiling hot. I tell no lie, it's barely even lukewarmth. Because of its base of mandelic acid, it stings. So that's the worst part about it. It's not a hot, but that lukewarmth will dissipate within 7 seconds. So apply it, 7 seconds, completely back to normal. From the ingredient blend, we have mandelic acid at 25%. Mandelic acid is antibacterial. It's also anti-inflammatory, but it also serves as a very potent tyrosinase inhibitor. As a more up-to-date ingredient, mandelic acid is everything that salicylic acid ever wanted to be, but more. So salicylic acid really isn't a very effective anti-inflammatory or antibacterial if you get all of this out of mandelic acid. As an ingredient, it's fractionated far enough away from original almond extract that even patients with a nut allergy should not have a problem with this. There's 5% lactic acid. The lactic acid in this case at 5% is designed to be a tyrosinase inhibitor. So we understand that particularly for your acneic conditions, you want something that's oil soluble. You're going to get that from mandelic. Lactic is going to be minimal for acne, but for hydration, for pigmentation, you'll have a benefit. The hyaluronic acid at 5% adds an element of hydration, but realistically, when we were doing formulation, we wanted safety. And I was inspired by, do you have toilet duck here? Yeah. Perfect. I was inspired by a toilet duck ad. And when they applied the gel into the rim of the toilet and they said the gel sticks, and it doesn't move and it stays there, I was like, that's what you want your peel to do. So if your peel is a very, very runny liquid, then there's always the risk of getting it into places where you don't want it to go. So we put in 5% hyaluronic acid, non-cross-linked, in order to bulk up the gel of the peel so you can see exactly where you're going, but also so it doesn't run into the ear, run into your nose, run into your mouth with that. As a mild corneolytic, there's pyruvic acid. This will serve effectively for retention hyperkeratosis here. Pyruvic is very up to date. What we realized is when we used it in the past, in the 1970s, that it was used up to 70%. A more up-to-date approach realizes that you get the same result whether you use it at 2.5 or whether you use it at 70%. It does the same thing. So by reducing it down, less irritation. Kojic acid dipalmitate is perfect as a tyrosinase inhibitor. The dipalmitate is a completely different fractionated form or ester of kojic acid, so you don't have the irritation coming through. Retinaldehyde at 0.1% will give you benefits for anti-aging, will give you benefits for melanosome transfer inhibition, but also can work preventative for patients prone to post-acne scarring. Moving into further advantage for pigmentation, Arbutin, which is a derivative of hydroquinone, and niacinamide, serve as both tyrosinase inhibitors, but also melanostome transfer inhibitors. So they actually physically slow down the relationship of exchange between the melanocyte and the keratinocyte. Niacinamide regulates sebum through its relationship with the lamellar granule. So niacinamide, for some reason, is able to balance the amount of ceramides and free fatty acids that are coming through and being released. So what you see is not just a regulation of sebum thickness or oil quality, but you also have a very powerful anti-inflammatory. Ferulic acid is put in for stabilization of the formula. There's nothing more frustrating than a formula which only lasts a month that you need to keep in the fridge and changes color and changes pH. So the ferulic enables stabilization. Copper peptides themselves, I've touched on these briefly and their role with superoxide dismutase. They're a very, very famous ingredient that are very renowned and very, very popular, but I'm going to be controversial here and say it's not the copper peptides themselves that do the job. Copper peptides activate the synthesis of what's called superoxide dismutase, which is the most powerful antioxidant that the skin can actually produce. So it's this that's doing the work, not the copper peptides. So we can see this ultimate synergistic effect with their role. And finally, you've got resorcinol and dimethyl isosorbide as your stabilizing ingredients. So at 5% resorcinol is not enough to give you a medium depth chemical peel. All of this is at a pH of 2.05. Despite this, you don't feel the ants crawling on your face. You don't feel a major tingle. It's literally lukewarm for about 7 seconds. Looking at protocols, you need to cleanse the skin first. Always tri-phase cleanser to remove all residue of makeup. You can exfoliate with the microderm exfoliant. You can then disinfect the skin as frequently, as often as what you want with the thinner prep. Apply your desired MG collection, do your Dermapen procedure. Now you need to remove residue. The reason why is if you draw any blood, particularly for a melasma case, blood in this case is a pH of 7.48. It's high. With this, if you then have MG collection residue, which will go up to a pH of about 6, it's sitting high, and your peel is 2.05. So if you put the peel over the top of blood or the MG collection, the pH is going to lift too high and the peel is going to lose its capability. So you must remove residue. To do that, what I suggest is gauze and cliniper. Thoroughly remove any dried up blood, thoroughly remove any MG collection, then dry the skin. Once the skin is dry, I have a preference because I use the sterile basic dressing kit. I just use sterile gauze from here. But if you want to use a mask brush, you've got that option. I just prefer single-use consumables. Apply it all over the face. My suggestion is to apply it on the most reactive areas first, watch and look, and then determine whether you continue or not. The Uber Pro is very predictable. We've never seen issues with it. But forehead first, then take it to the chin and jawline, sides of the face, work your way up and in. Don't apply it on the lips, don't apply it on the eyelids. Once you've left it on, 30 seconds to 3 minutes will do the trick. For the first time patient, I think 30 seconds is fine. But there's no major time limit that the peel is going to do something unexpected if you don't hurry up or if there's 10 seconds extra. It's really just to get you into a set protocol of observing. To neutralize, despite the fact it's self-neutralizing, put the Hyaluractive 3D sculptured mask all over the top. The mask is a pH of 6.5, which means it'll instantly neutralize the peel. The mask remains on for 7 minutes, 15 minutes, up to 45 minutes if you even wish. The mask comes off. You can then apply any remaining MG collection. Pressed onto the skin, don't vigorously massage. and then apply vitamin-rich repair, and your recover, as always, your post-op non-negotiables. No substitutions here, because this is the part when you start substituting and you put something which either traps heat in, or you put a hybrid SPF on, that's going to cause the irritation. So with this, stick to the rules of your post-ops. So the patient has been dermapenned. This is Uber Pro. It's a bright yellow from the retinaldehyde. Just using dry gauze cotton onto the forehead first. So you can see the color of the patient's face following Dermapen. It's not really going to change with application of the Uber Pro. Watch and look should anything unexpected happen. Then we move to the chin and jawline and the outside of the face. Work our way in. These are real patients, so we can't hide their facial expressions if they're in pain or if something's not right. You can see that the patient's perfectly comfortable. It just smells weird. The patient's been treated for recalcitrant melasma, so there was some pinpoint blood on the tops of the cheeks there. Leave on 30 seconds to 3 minutes, and then we're going to neutralize with the highly active 3D sculptured mask. I want to go through some case studies now, and then from case studies, I'll open up the forum for you for questions and answers, and then we will get into our practical. We also have time because we've got a smaller group today that if you want me to go into some diversion mode into some other areas, I can do that. That's not a problem to do so, just so long as I'm not covering any of the content that I'm going to cover for tomorrow's topics. I want to show firstly the safety of microneedling with Dermapen. This is important because I teach in many international markets, and particularly for my market in Southeast Asia and India, but also for my market in Polynesia, in the Pacific Islands. The biggest problem that we have is post-inflammatory hyperpigmentation. There's no laser, there's no IPL, there's no chemical peels, there's nothing that's going to risk this pigment. So the combination that we see for both of these patients is Dermapen, DpD dermaceuticals infusion, and then your Uber Pro over the top. So this is one of the key images I use for melasma for congresses, and when I need to show the safety, particularly on darker skins. This is after one treatment. One treatment is always great, but realistically, it's not typical. So I would say to a patient, look, there is no golden number, but expect at least 3 to 5 procedures as your treatment program. You cannot over-Dermapen in regards to if a patient wants to see you every 2 months for the rest of their life. That cannot be problematic, but you can over-Dermapen in regards to your intervals. So remember, no blood, blood procedures should not be more frequent than every 6 to every 8 weeks. Post-inflammatory hyperpigmentation, 3 procedures, the same process of Dermapen plus DpD dermaceuticals, NG, and then your Uber Pro. So I liken this whole process that your Dermapen is activating regulatory growth factors, and then for your deeper procedures, collagen, angiogenesis, elastin. That's essentially working from the bottom up within the skin. When you deposit your MG collection with your needles, that then allows nutrition and drip feed within the skin, and then your Uber Pro is working from top down into the skin. So you have these 3 intervention points to essentially speed the process up. What you'll like about Uber Pro is that peels are very inexpensive to work with. So for you as a practitioner, it's not suddenly adding a whole expensive consumable, it's very affordable. So then this gives you flexibility for what you'll charge your end price. These types of combination therapies, a Dermapen experience and treatment is very different to just a microneedling experience. And we certainly see that evidence with the before and after images, but the synergistic effect. Further synergies that you can do within the procedure also include red LED and also near infrared, which we produce as the technology. And then again, this gives you another level, another aspect of treatment performance. Theoretically, I would not encourage treatment of this stage 3 moving into stage 4 acne. But this patient from India, this is 3 procedures and the 3-in-1 combination. So you have reliability, safety, efficacy. There's no medication. So with this, Dermapen, MG collection, Uber Pro. Safety for the Uber Pro can be used anywhere on the face and body. So you're not restricted. At the moment, I'm currently working with a colleague to get protocols for intimate rejuvenation for the outer labial area and for peripinal and perianal area using Uber Pro, but also using the MG collection BL. This is a huge market in some countries. And then we see for classic acne, 6 procedures. From pigment to acne, I now want to share with you just some protocols of what you should be using and how to treat. Patient comes in with pigmentation. Your treatment, you need to determine whether it is dermal or whether it's epidermal. You're going to determine that based on color. So with this, if you find that it's more yellow, tan, orange in color, it means that the pigment is sitting more superficially in the epidermis. If it's more blue, green, gray in color, then it's sitting deeper down, potentially dermal pigment. You'll also notice that the dermal pigment tends to be more block and macular. So once you determine that, you're then going to understand the treatment will be no blood, red skin, epidermis, or the occasional pinpoint blood and red skin, which is going to be for your melasma. Your treatment intervals, you want a controlled but resolved inflammatory response, which means every 2 to every 4 weeks. No sooner and preferably no later. You're going to infuse into the skin the MG collection, BL, predictable, reliable, and then you can upgrade if you wanted to add in potentially the MG collection HA35 plus. So you would then add in a premium extra for that cost. And then you could add in the Uber Pro, which again would attract a higher price point. None of this is really taking any extra time because the Uber Pro is only on for 30 seconds. And if you mix and blend your MG collection, it's still the same time. And then again, you could upgrade if you wanted to put on a red LED over the top. So you've got these options to give you varying price points. What I want people to try and avoid is putting Dermapen at the lower end of the spectrum. So we need to understand that for all major brands, whether it's an injectable, whether it's a filler or whatever that is, they come at a premium cost with a premium reputation, premium training, and premium product. If you start pricing too low, then you're just joining the other devices. That's a problem. For your treatment, if the patient comes to you and commitment to product is difficult due to cost, due to lack of attention span, why not begin with a starter kit? The starter kit, you have your correctives in 15 mils, and you then have your cleanser and exfoliant in 60 mil sizes. So this is going to be the most affordable way to get someone onto their preparation, their antibiotics that they need post-op, or whatever the doctor would prescribe after an operation. The most affordable way is going to be this. The second, if there were 3 products out of all the options that you could reduce down to for pigmentation, the 3 that your patient needs to take home in full size include bright light, your potent tyrosinase inhibitor. You then have your retinol active. retinaldehyde as a melanostone transfer inhibitor, and then sunscreen, your cover recover. The cover recover, because of the tint, means that you can easily reapply it throughout the day every 2 to 3 hours. So it's very interesting. I can't remember which country it was in last week, but it's a language I don't speak. And I could hear them talking away in the front row when I was talking about sunscreen. And I said, I can understand what you're saying. Because my background is Australian originally, there's this misconception that I'm promoting sunscreen based on an Australian experience. Number 2 for pre-skin cancers at the moment is Sweden. So it's got nothing to do with where you're located. For anyone who's treating pigmentation, I'm very strict. If you're not willing to wear sunscreen 4 times a day, don't bother. There's no point with it. So you need to be strict. Otherwise, for the ultimate program for the patient who is high-tech and anything and everything for that, you have tri-phase cleanser. Apply your water-based antioxidant first in the morning with bright light over the top, antioxidant cocktail plus retinol active at night time. Notice that this is very realistic. Moisturizer is cute, but it's not going to solve you for this. What's going to give you the physical benefits is sunscreen, retinoid, tyrosine inhibitor. Having a look at acne. Again, you're creating a controlled but resolved inflammatory response. As I drew up with retention hyperkeratosis before, your congestion's up the top. It's not down the bottom of the follicle like the ads on television tell you with this. So as such, your treatment only needs to be superficial. You're looking for no blood, pink to red skin. So pink is granulosum, red is basic. So depending on your severity of acne. I don't recommend that you treat acne stage 4, which is acne fulminant or acne conglobata. There are some new visions for patients who are on an isotretinoin drug. So Roaccutane, Accutane, Isotane, Orotane. Traditionally, the dermatologist would weigh you, and whatever your weight is would then become the milligrams that you would take. So if you were 60 kilograms, you would take 60 milligrams a day. There's been too many complications with this over the years reported. So you'll find that more up-to-date doctors will have a lower dose over a longer time period. So with this, if your patient is on 30 milligrams or less per day, so for some patients, they may take 60 milligrams every 2 days, just depending on how their dosage takes. But so long as it's 30 milligrams or less taken per day of oral isotretinoin, you can still treat. If your patient's on oral antibiotics, it's not a problem. Just be aware, particularly with doxycycline, it will make you more photosensitive. So sunscreen is important. And for some antibiotics, it may make their skin bleed easier. Not a problem, just adjust your needles accordingly. As an upgrade to your procedure, you're going to use the Energy Collection, Clear Up or CLR as your gliding medium, but your physical infusion. You can then upgrade with the Uber Pro over the top, inexpensive, effective, works from the top down. Your treatment's going to be every 2 to every 4 weeks. There is a problematic acne skin kit that will give the patient everything that they need. Generally, these kits should last the patient around about 6 to 8 weeks. So they're generous in size and it will give them what they require for pre and post-op. Otherwise, your 3 non-negotiables from the full retail range is Clear Foam Cleanser. I'm going to cover this topic in extensive detail tomorrow, but the Clear Foam Cleanser, the reason why I'm recommending cleansing for acne has nothing to do with the fact that it's a cleanser. It's all going to link in with pH. It's all going to link in with pH logarithms and linking in with cleansing methods that many acne patients will undertake, which guarantee it's going to make their skin worse. But I'm going to cover this tomorrow. You need a broad spectrum disinfection, cleaner prep. They can spray this any point, any time for antibacterial, antimicrobial, antifungal, antiviral, anti-spore. The Clear Lotion, understanding that acne patients, generally because they're younger, are not going to be able to commit to as many products. So this is your corrector and a moisturizing treatment in one. It's non-drying, so you can use it as a spot corrector as well. What I also like, if you do have a patient who comes in and they are from the acid heritage, so they are used to using acids on their face every single day because that's what they began in the 1980s and that's what they need to continue on. If someone says, I noticed that DpD Dermaceuticals does not have an acid product that I can apply every day, there's 2% salicylic acid in the clear lotion. So if someone wants to use occasionally a resurfacing acid-based product, you can actually use the clear lotion as this type of product. I recommend in conjunction with the retinol active. Of course, then if the patient can afford more, we then add in the other products. For anti-aging, you're drawing pinpoint blood as a minimum. So there is no such thing as a baby anti-aging procedure where you're working more superficially and expecting collagen result. Your treatment, because you're drawing blood, is every 6 to 8 weeks for an adult. With this, you will be infusing the MG Collection RAS into the skin. You can use the Uber Pro as a superficial refresh, particularly for dyschromia, but for physical wrinkle depth, this takes us into advanced Dermapen, which is the Uber MD, which I don't cover today. For procedures, remember that you can still alternate your treatment depths. So rather than seeing your aging patient every 8 weeks, you can perform the first procedure and then 4 weeks later, perform a superficial procedure to treat and target the hyperpigmentation and dyschromia. 4 weeks later, blood, 4 weeks later, no blood. There is an anti-aging starter kit, which makes things more affordable for pre and post-op. Otherwise, your 3 non-negotiables: vitamin-rich repair during the day, retinol active at nighttime, we have vitamin A esters, and then we have the retinaldehyde, and of course, sunscreen. This is the most important thing for any pigmented or any aged complexions. For scars and stretch marks, you'll find that the program is relatively similar, every 6 to 8 weeks. The only thing I'm going to change here is if you have a child, for post-acne scars, traumatic scars, I'm going to hand over to the medical side, but for post-acne scars, you can treat as often as every 4 weeks. Children have a higher collagen potential than what adults do. So the statistic is that collagen will deplete at a rate of about 1.7% a year from the age of 20 onwards. But otherwise, for an adult, every 6 to 8 weeks, you can use the MG Collection RAS, but you could even use as an upgrade or a more expensive premium option, the MG Collection HA35+. For stretch marks and for scars, you can use what's called a cross technique, which is chemical reconstruction of scars and striae, and I'll cover this tomorrow, with the Uber MD. Home care, there is no pack, but you only require 2 products. Retinol active first, and then scar over the top, morning and night. You can reapply the scar as frequently as possible. Finally, for rosacea, despite the fact a rosacea patient will say to you, I'm sensitized, my skin's reactive, and you want to put needles in it, the concept of being able to regulate growth factors, particularly that balance angiogenesis, but also deposit new collagen for a redensifying effect of both the extracellular matrix, but also the epidermis, can deliver positive benefits and results. Because you're drawing blood treatments every 6 to 8 weeks, you have the option of either the MG Collection HA35+, or you can use the MG Collection RAS. Consistent pinpoint blood, note that a rosacea patient will bleed easier by comparison to a patient with thicker skin. So you just adjust your needle depth accordingly. I suggest the pre and post-op kit, which will give them everything that they require. For the rosacea patient, your non-negotiables is cleanse. That's very strange, but if you start changing the natural biome, if you start creating an alkaline environment like over-cleansing for rosacea, your issue is going to get significantly worse. You have a barrier function problem. Secondly, antioxidant cocktail to re-establish barrier function through niacinamide, stimulation of lamellar granules, and also reduction of inflammation. Skin veneer plays a very, very key role here. So again, it links back to barrier function, which in turn will reduce the associated inflammation. So that concludes the formal part of the training today. So we've covered all basic aspects of Dermapen. So at this point, you should feel confident as to why you want a Dermapen for and why you should be using it every single day, multiple times a day, and why it will become the most used device within your clinic. Secondly, you understand that Dermapen is more than just about the needles. Now being able to infuse and add and create your own complexes of meso agents to go into the skin, you now have greater control as to the results that you're going to achieve with your patients. You also understand that depth is about a visual endpoint, not a figure. We understand that microneedling is more than just scars and anti-aging, but also understand that through our combination therapies, we're able to create a three-dimensional approach to skin that's quick, fast, comfortable, affordable, and versatile, and appeases the wants and needs of the modern patient, but with suitability for 99% of people coming through the door, with the exceptions of the contraindications that we went through. What we also see now is opportunity. And for those of you coming again tomorrow, you'll see that this intensifies by about 3 to 4-fold when we look at topics including acne, when we look at topics including scars, on how you can control even further to accelerate the results. But understanding that this is a synergistic approach, and that's the success of Dermapen 4, the MG collection, DpD Dermaceuticals, but also the Uber peeling system to give you a complete approach on all aspects of the skin indication and all aspects of in-clinic care, home care, and ongoing maintenance. So now I'm going to open up the forum for questions, thoughts, ideas, and then we will treat our patients. So we're running about 20 minutes early, so there's no rush in anything. I usually see that. So talk to me. We can go into diversion mode. I've got a whiteboard, so we can talk about it.
How fresh a scar, let's say C-section or
The
something?
problem with this is that there's two schools of thought. And normally I would say whichever school of thought has more clinicals and has more opinions on it, go with that one.
Okay.
They're 50-50. So you have the Fernandez school of thinking, which says treat quickly and treat regularly as soon as the trauma is being created. I don't support that. The reason why is when we look at the role of psychotricial healing, what activates pro-fibrotic growth factors, what activates all your problem is major trauma. So if you have an unresolved trauma, so you've got a recent surgery or a recent wound, the risk is if you go in a microneedle over the top, which is re-traumatizing the area, that the body is going to react with the production of pro-fibrotic growth factors. The response to this is that, well, scars are really most common in darker Fitzpatricks, Fitzpatrick 5 and 6 from Africa, but scars are also just as dominant and just as high a risk with a Fitzpatrick 1, Scandinavian, Celtic, Anglo-Saxon skin. So with this, my thought process is to avoid this process of psychotricial healing, wait 6 months at least. That means based on your process of wound healing, once you've waited 6-month time process, you've now gone from proliferation into maturation, which means that you're not intervening. The example that I use for this, so I'm Fitzpatrick, late 2s, Germanic skin, I should be pretty much impossible to scar. I have a massive hypertrophic down my arm here. The reason why I have that, I was 6 years old, wind in my hair, it was summer, I was riding on my bike as fast as I can and doing that thing where you slam the brakes on and hope for the best. So fell off my bike. And I remember sitting at school, I had this massive scab on my arm. If I had left that scab, I would have no scar. And I would sit there picking at the scab until it would bleed, flick it on the floor, and then leave it for a few days. Then the scab would reform, then I'd pick at it again, bleed, reform, and keep on that process. So when you create multiple wound healing responses and there's no resolution for what you're trying to achieve, then the risk is always going to be the release of profibrotic growth factors. And whilst we've always had our blinkers on saying, well, this is only a risk for darker skins, the reality is that anyone can produce a profibrotic growth factor. Anyone has this potential, and with this will also come the consequently the risk of post-inflammatory hyperpigmentation. So for a fairer skin, that can be like macular red erythematous marks, so you just end up with red marks all over the skin, or for a darker skin, that's going to be dark skin. So for Dermapen World, myself, I would recommend holding out for about 6 months.
You can use the cream though, kind of thing.
Absolutely. So the first thing you want to do is clinic prep. Even whilst you still have sutures in, is clinic prep, clinic prep, clinic prep. Once your sutures are out and you're off your antibiotics, retinaldehyde, using your retinal active, and then the scar cream over the top. Yeah. Be liberal with the scar cream.
Every night.
Scar cream over the
I
top.
would go 4 times a day.
4 times a day.
So keep the area soft, keep the area flexible, massage the scar cream through, and that will give you, yeah, and it will give you nice movement, nice flexibility for healing.
So clinic prep, the retinol.
Clinic prep whilst you're still in post-op phase.
Yeah.
So if you've got sutures in, or if you're still on antibiotics, you've just come out of surgery, go clinic prep crazy. Then once the bandages are off, then you can start clinic prep, retinaldehyde with the retinal active, and then the scar over the top.
Yeah.
And then once you're through, say, week 3, week 4, then you can take away the clinic prep.
Okay.
Wound tension and wound infection are also key areas as to why you get a scar. So that's the reason why I recommend clinic prep frequently with that.
Yeah. And then old scars, just go in with the retinol and the...
And still with the scar, but understand that particularly with an older scar, if you remember back to the colours, a newer scar is generally going to be red, blue, purple. If you've not got that, it means due to abnormal collagen deposition and abnormal extracellular matrix, your vessels, which should be here, got pushed down, or they're doing a big zigzag with that. So it just means that your treatments will need to be deeper. So that's the time when you can go down to the hypodermis instead of just into the dermis itself. You'll know when you do treatment. So you're with a patient, you're on their cheek and there may be a scar, or you're on their chest and you're thinking, that's such a 2 millimeters. And you're there at 2 millimeters, you're doing your stripes, you do your imprint, and still nothing comes out. And you're like, okay, that's my key sign that the vessels are sitting a lot lower. So this is where you're going to pull out your 2.5, potentially up to your scar treatment setting.
Thank you.
And also with stretch marks as well.
Same thing for colour. So for stretch marks, your issue is actually from the bottom up, whereas with a traditional scar, it's top down. So to explain the difference.
Keep dropping down. The board.
What was that? I'm sorry?
The board keeps dropping down. I think it's loose. You need to like unscrew it.
Okay, as long as it doesn't.
And the other one's fine as well.
Okay, so for your traditional scar, you need to have a trauma that extends into the dermis and beyond. So we'll go into these areas tomorrow. So remember that collagen is not just a feature of the skin, you have muscles, ligaments, tendons, and bones down that. So for a traditional scar, your trauma is from the top down into the skin, and then you create a process of cicatricial healing that fills up. With a stretch mark, what you have is a pressure that creates a dermal tear. So instead of looking like this, it looks like this. So your concentration tends to be around this area here. So with stretch marks, you do have a little bit more room for flexibility. Because your trauma is not coming from the top down, it means that you can probably start treating a little bit sooner, say about 2 months. But be aware that you're not going to get a preventative agent. So if you have just become pregnant and you're going to expand, no dermapening now is going to prevent those stretch marks from coming through at 6 months' time. Or if there's going to be major weight changes or things like that, it's not going to be a prophylaxis or a preventative. In that case, you've got to treat whilst they're there. Understand though that the more red, blue, purple, the easier it's going to be. So that's called striae rubra, which is red, or striae cerulear, which means that they're bluish purple. That's going to be easy to treat than striae alba, which means white, or striae nigra, which means striae black, stretch marks on darker skins.
Yeah. Thank you.
So with that, are you coming to tomorrow's session?
No.
Okay, we need to get the recording, but a further way that we can rejuvenate both the stretch marks and particularly for atopic scars is the vitamin D. But it's not suitable for all dysphagic skin types, but it's a way that you can create a mechanical rejuvenation plus a chemical rejuvenation with your peel, and then with the MG collection, you then get a biorevitalization with that. Any other thoughts, questions, observations?
Yeah.
Brain freezing.
Well, tomorrow I'm about a CBD entry tomorrow, so with the elixir and all that. Yeah, so just kind of, yeah, and acne treatments as well. I haven't done any acne. Haven't used.
As in treatment for acne itself, you've had no experience with, or?
Yeah, I have never treated like that stage 1 to stage 3 with Dermapen.
It's surprisingly successful with this. Note though, and this is an area for tomorrow's session, when you have an imbalance of acne bacteria, so Proteobacterium acnes, which is now called Cutibacterium acnes, when you get an increase of this, it's going to recruit what's called Staphylococcus epidermidis. So it's actually 2 bacterium that's giving you your acne, and these 2 will have a relationship that's very reliant. When you oxygenate or when you add the right disinfecting agent, you instantly kill the acne bacteria, which leaves the staph. The staph is harder to reduce, but it will happen. So normally you'll find that you'll get a call on day 2, day 3 saying, you made my skin worse. Expect that, or actually prepare for that and say, you're going to hate me on day 2, you're going to hate me on day 3, you're going to feel like skin's worse, that you feel pussy, but wait till day 4, day 5, and then it will resolve. And that's when you've got real control of the Staphylococcus epidermidis. So for that type of patient, if they're nervous, the Cliniprep is inexpensive, so that can be a product that can just keep spraying on their skin throughout. But as we covered this morning, the acne protocols, and we're going to cover in extensive detail tomorrow, it goes against what we think, because we think that we're spreading Cutibacterium acnes all over the face, but remember that it's anaerobic. So it's not going to survive.
Yeah, I've seen amazing before and after pictures.
Yeah.
And it's like unbelievable.
We were canned when we first started using microneedling for acne and presenting this particularly for dermatology congresses. There was like shock and shouting and all sorts of things, but then being able to back that up and explain the physical understanding as to what controls and the success of this. We're going to go into gruesome detail tomorrow for acne and what creates your natural exfoliation for attention hyperkeratosis, but also understand that there's so many things consumers do and are taught that are giving them acne without them even realizing. And so much stuff we see on social media, like that is gotten worse than we can possibly do. recover your acne 10 times quicker.
Sorry, just to go back to scars for a second.
Yeah.
What's your opinion on, say like that, like a 14-year-old has a terrible accident, is scarred?
Yeah.
Do you
so
treat?
the problem with this is that 14-year-olds grow. So you need to determine, are you doing scar revision or are you doing scar management? With a 14-year-old, you cannot do scar revision because as they grow, the scar's going to grow with them. So you may be able to perform some procedures to reduce the effect of the scar, but you're not going to be able to turn that from a management into a revision until they stop growing.
Okay.
So for things like post-acne scars, not a problem. But if you're trying to treat childhood traumas,
you're better off just to wait.
You can go into management, but it just depends on, you need to be very clear that this is not an end result.
Yeah.
This is a work in progress.
Okay.
And so long as they understand that and they're not going to call you up in 2 years' time and say, hold on, it's still here, then you've got to be realistic with what your expectations are and what theirs are. Okay. Consultation is everything.
Yeah. Yeah.
Is there any complications to the working at all?
For the pro? No. Only if they're allergic to any of the individual ingredients, which shouldn't happen with that. But otherwise, you've got a very, very reliable product. As a company, we don't heal rosacea skins. For that, I know that there's other protocols with other companies that do that, but barrier function is barrier function. And if you start removing barrier function on rosacea skin, you're going to have a lot of issues and problems. So I wouldn't use the probe on anyone who has a compromised barrier, which is going to be rosacea.
I find it very interesting using the sodium balls, what do you call it? At the
sodalite.
The sodalite for the lymphatic stimulation.
So it's a more holistic approach for that. Certainly for the medical side of things, they would not do that. But I mean, if you need to extend, because I heard some figures being thrown around at lunchtime, and I'm like, it's too cheap. I think 160, 180 for a Dermapen procedure, it's too cheap for that. So if you were to go into a medical clinic and they're going to say, oh, I'm going to give you a botulinum toxin treatment, and it's only this, you're like, what did you do with it? Why is it so cheap? There's got to be a clear differentiation between what's an original Dermapen procedure and pushing that. We do try as a company with the distributors, but also through our own legal department to shut down when people are not using an original Dermapen. But you've got to put this education into practice. You've got to put in your knowledge, but you've also got to be strict with patients for that. And always, you've got to have a correct duty of care for the patient.
It's like an insurance for you too.
Absolutely.
You have a clinic and like that, you want to a whole other level of treatment, you know,
yes.
And you want like security for yourself, that and peace of mind that you know that it's not going to happen to your patient, but it's going to happen the best outcome. And I always say that to my own patients that you have to follow the protocol because I need to know that your skin is going to
do exactly what it needs to do. It's got nothing to do with the sales process. That's the reason why, particularly when I go through the individual skin indications, that I'm not going to say moisturizer is going to solve everything for everyone. The only person moisturizer is going to solve this for rosacea. So this is where you look at your non-negotiables, but also understand.
And with rosacea as well.
Yep.
Do you know when you have just when you treated their rosacea skin, when would be kind of like, I don't know, when would be the best point to do the skin on a rosacea kind?
You can do it relatively quick, but to be really blunt with rosacea, your issue is diet. You don't fix the diet, you're not going to have any results with that.
Yeah.
So there's a lot of old data that looks at things such as mites on the skin. That's very rare. If Demodex mites was the issue, then your antibiotics should work. Why are your antibiotics not working? Because there's not Demodex mites with that. So the key argument for rosacea actually comes from Australia from 1983. It refers to what's called Helicobacter pylori, which is a small intestine bacterial overgrowth, otherwise known as a SIBO. I was not planning for this topic today, so I'm going to work slowly because I have to. So, this argument works in two ways. I'm going to show you the first way. There's three arguments for rosacea. The first is called Cathelophyllins, which I'll explain. The second is called Dermapen mites, which personally I think is a very, very dated approach for it. It can be the case in some patients, but it should resolve relatively quick. And then the third is called small intestinal bacterial overgrowth. So, yeah, so a cathelophyllin is a modulatory host immune peptide. And so with this, essentially it's like a soldier. And everyone has these soldiers within their skin. So we can find them in a variety of cells. With these soldiers, I want you to imagine that there's an army barracks. With the army barracks, if you've got the right number of soldiers within the barrack, then that's fine. But imagine if they keep sending more soldiers to the barracks and there's no war, there's no exercises, there's nothing for them to do. Eventually, when you've got so many more soldiers, you're going to have this process that just says, you know what, game on, let's fight. So the Cathelophyllins argument is when you essentially have too many of this immunomodulatory host defense peptide and it ends up fighting on itself. The first aspect of Cathelophyllins that you're going to get is going to be a whole release of inflammatory peptides within the skin. Cathelophyllins, first off, will activate what's called KLK 5, 7, and 14. KLK stands for kallikrein-related dipeptidases. When you activate KLKs, these are actually one of the key agents which work in getting your skin to regulate desquamation. So if you overactivate through this fight an inflammatory response, which then overactivates an enzyme which creates overexfoliation, it means that your epidermis is turning cells over far too quickly. So the KLKs actually fit into a category of enzymes that's called SCCEs, or stratum corneum enzymes. So an overpresence of these soldiers, which creates infighting, then creates an overactivity of these enzymes, which then start turning the cells over faster and faster and faster. So you have absolutely no barrier function. In response to this no barrier function, the inflammation then continues on going lower and lower and lower and lower. So this then leads into the dermis, the release of what's called MMPs. This may not be spelled entirely right. MMPs are called matrix metalloproteinases. There's two. One's called collagenase. I will make this process easy in a moment. And the other is called elastinase. Under traditional wound healing, in your maturative response, you need to, it's like making a sculpture. You need to finalize the details of your piece of art, of what you worked. What creates the remodeling of collagen is collagenase and elastinase. So they refine the newly formed protein fibers. The problem is though, as these refine, they remove the excess, they make everything look great. But if you then have an overpresence of MMPs, then they're going to start eating everything away. So what happens with the argument of Cathelophyllins is that you have this overpresence of these little soldiers. When they begin to infight, then it increases and makes an overexfoliation of the epidermis, which means you have absolutely no barrier function. When you have no barrier function, it means you have absolutely no hydration for this. So you have a very thin, irritated epidermis. But then this inflammation activates a process of MMPs, which means that they begin to attack the collagen fibers, which thins out epidermis. And then as a response of that, the body goes into an unresolved inflammatory response, which means that your vascularity, you've got thin, red, irritated, grumpy skin. That's one of the arguments for rosacea or cathetopathy. To now turn this the other way around. If you have in your stomach needs to be acidic. Your small intestine is broken into three parts. So your duodenum, your jejunum, and ileum, I think. With this process, 95% of your nutrients are absorbed through the duodenum, the first part of the small intestine, but they're absorbed in an alkaline environment. So there's an argument that's very strong that your stomach, which needs to be acidic, which then harbors what's called a small intestine bacterial overgrowth, or a SIBO. You can remember overgrowth. Its name is called H. pylori, or Helicobacter. Helicobacter pylori should reside in the stomach, that's not a problem. But due to diet, due to lifestyle, due to inflammation, when your small intestine, which should be alkaline, so it should be sitting about 7.2, if that becomes more acidic, then it creates the movement of Helicobacter pylori from the stomach, where it should be, into the small intestine, where it's not supposed to be. When you have a complete change in environment, your body then goes into a full inflammatory mode. So the presence of Helicobacter pylori in the small intestine then creates the release of bradykinin peptides, and these are inflammatory peptides. If you've ever had a really bad day and you're stressed and you're upset and you're running late for something and you feel this red dot just above your belly button start to build, your chest gets red, your neck gets red. If you're ever passionate or ever in a fight and really angry and upset and you feel this redness start to build up and it's hitting your neck and then up to towards your face, this is from bradykinin peptides. Once we start releasing bradykinin peptides, they then create vasodilation, and then vasodilation, vasoconstriction, vasodilation over a long period of time creates weakness on the vessels. But the other argument for rosacea is that instead of people have too many cathelipidims, which leads to thinning of the epidermis, thinning of the dermis, the argument is that people have an acidic small intestine, which then increases your rate of bradykinin peptides, and then the increase of bradykinin peptides over a long period of time then activate matrix metalloproteinases, which then in turn activates an overexfoliation of KLKs. So the argument for rosacea can go from top down, or it can go from bottom up for this. So what do you need to do? Number one, you need to realkalize. So if this is surviving with small intestinal bacterial overgrowth, Helicobacter pylori, if that's surviving in a highly acidic environment, then you need to make your diet more alkaline. So you may need to work with a nutritionist, you may need to work with a dietitian, your doctor, in order to achieve this. In addition to this, you also need a probiotic and prebiotic, something to rearrange what's happening, the imbalance within your digestive tract. Of course, if this isn't working, then again, work with the doctor. And then from this process, you need to have a look at what's going to reduce inflammation. We see B group complex vitamins can reduce inflammation, but we also see the role of agents including omega-3s and omega-6s, so essential fatty acids, also reduce the role of inflammation. So if you can then enable systemically a diet, be aware that triggers such as alcohol, such as high sugar, such as high spice, and all of this are problematic because they're reinforcing that acidic environment for this. So these are all going to be triggers. But if you can achieve balance through here, then a lot of this will fall into place relatively quick. So if you then support the machine with your Dermapen procedures, you can achieve a level of longevity with this. There's a whole host of tests that the patient's doctor can run, so they can run hydrogen and methane tests and things like that, but normally you'll find that if the patient has this type of effect here, that normally they experience a lot of discomfort, either that they're very bloated, or they feel that they get a lot of diarrhea or a lot of constipation, which will support this type of imbalance.
Okay.
So sort diet out, this falls into place relatively easily. Do this without a diet, then you go into maintenance mode, which means that you've got to continue on with the program and with your procedures. Which then leads on to, I guess, another question of how often should I be performing? So once you've achieved your end result, I think you can then perform some maintenance procedures once a year, once every 2 years. But again, you can't over Dermapen the skin, so long as you're sticking to the correct treatment intervals. Okay. So let's take a break. Any other questions before we get onto that? Sorry, that was a very long answer for a very short question.
What about capillaries?
In which way? Which regard?
Like, you do
telangiectasia.
And it's capillaries, so it's very visible veins and everything, redness.
Okay, so telangiectasia. So telangiectasia, again, has an element in some case of radiculin peptides. So what happens is you have inflammatory peptide that creates vasodilation, vasoconstriction for this. The difference is with rosacea. Can I get rid of this?
Yeah.
So close up rosacea looks like this. Then the rosacea symptoms come on, which then say make more capillaries. So you end up with this whole pulling network. By contrast to telangiectasia, my drawing is really bad. What happens is, rather than a poly network of vessels, the existing vessels, the blood comes through, then for some reason, vasoconstriction, vasodilation, the blood begins to pull, so collect within this area, which then creates pressure on the vascular wall. The common term for this in the video world is broken capillaries. There is no such thing as broken capillaries. Broken particular groups with that. So in both cases here, if you can see the vessel, then you have a very thin epidermis and you have a very, very thin dermis. For your rosacea patient, your issue is overexfoliation, and then you have an attack of these collagenase and also elastinase enzymes. But for telangiectasia, generally what you have is due to prolonged sun exposure, ultraviolet damage, you've then eaten away any remaining collagen, which then leaves you with a very, very thin skin. So from a treatment perspective, it's not as diet focused, but from your protocols for this, it's about redensifying the extracellular matrix and redensifying the epidermis itself. What controls these vessels is called vascular endothelial growth factor, but also platelet-derived growth factor. They in turn will control angiogenesis, so growth and development of new capillaries. But what that also means is, as part of resolution, as you move from your proliferative response into your maturative response, you see the removal of anything that's no longer required. So part of the repair process can rebalance for some of this capillary network, also in the process of redensifying both the epidermis and also the dermis, we find that these are less visible as well. So again, the process of thickening and stimulating collagen will give you a response. Sunscreen, 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 sunscreen. It's never too late.
So you need to target your fibroblast to help resolve that.
Yes,
yeah.
For rosacea and this type of telangiectasia, you need to draw blood.
Yeah.
But note that they'll draw blood easier by comparison to your average patient with thicker skin.
Okay.
So it might be very tiny dip, is it?
Sorry.
The dip can be just, just up to, for example, 0.5.
No numbers.
Yeah.
No numbers.
Okay.
Pinpoint blood, but against you there.
Okay. Yeah.
So these need to be pinpoint blood as a minimum. The patient will bleed easier, whatever that number is.
All right.
But you'll need to adjust accordingly for that. But particularly for this kind of patient, this is where you put in an active retinoid and sunscreen.
But some of the times they would like to avoid the microneedling because of that problem, of the capillary skin. So they don't want to go for that treatment for Dermapen. They are just afraid that it will be worse.
No.
After the
the best thing you ever do.
I think so.
So look, there's two options for this, and we need to be honest with patients who want the world now. If you laser this, you will remove what you currently see now in the mirror, but you have no preventative effect of what's going to happen in the future. If you Dermapen this, you're not going to remove it straight away. You're still going to see it for the next 3 months, 6 months. But then, once you rebalance, you have longevity with your procedure.
So it's a bit very long.
Yeah. So in some cases, you may be able to zap it first. It'll remove what you see now, but it won't prevent anything from coming back or correct physically what's in the skin. And then after you zap, you can then do Dermapen.
I would do a lot more Dermapen with capillaries. Yeah, it's amazing. And then we do then dye therapy at the end and just a little larger.
Okay.
Yeah.
So there's a lot of versatility with it.
My experience working with lasers over the years like that, we worked with so many different types of lasers, treating capillaries. And
they are, but they remove what you see now.
Yeah.
It's the same thing with pigment.
Yeah.
There's unrealistic expectations. I will not touch a skin that is not wearing sunscreen every single day and reapplied every day. There's just no point in doing that. So when I look at, say, either pigment or vascular, you can remove that easily with laser and it removes what you see right now when you look in the mirror, but it has no preventative effect for the future. That's where the whole concept of regenerative medicine with Dermapen gives you value, it gives you an investment for what's happening in the future. I mean, there's ways to combine and add it together, but what I was want to show is that if you want to really cheap affordable way, you have a clinic and you have a choice of 120,000 euro laser, and you have the choice which does two things, hair removal, vascular and pigment, and then you have the option of the Dermapen. What's going to give you more versatility at an affordable price, but return on the investment? It's the Dermapen. Any other questions?
Sorry, I have one more.
Sure.
Did you say you could go directly over milia?
Yeah.
Okay.
Milia are when you have a look at where everything is sitting in the skin. Milia is sitting there. So you have a small collection of unresolved keratin protein that's just sitting up the top there. So your depth is very, very superficial. If you want to just speed it up with Pro, which is anti-keratolytic, so corneolytic, which is a keratolytic and also a corneolytic, it's able to target that. Then, if you were to do your follicle in response to this area, the keratosis pilaris is sitting there. So you can see that they're really, really superficial treatments. We don't have issues like stucco keratosis, but again, there's still soliciting through that area where it's very, very superficial.
Perfect.
Can you treat keratosis?
Yeah. So it suggests the quickest, most satisfying way to do that would be to use Dermapen superficial, so it's just sitting there, Uber Pro over the top, and then the patient would use something like the Pura lotion every day or every 2 days, which is salicylic acid, which will stop the keratinization.
Right.
And then, of course, exfoliation with the microdermal exfoliant.
So what cleanser will you use then? Will you use
What was the question, sorry?
what would the cleanser you use on the body? Will you use the body wash? Would you recommend to use?
Just use microdermal exfoliant. Generally, so the more oil you add, the more diluted it becomes. So that's abrasive. And then if you use a jar, it'll become exfoliating.
Okay. The clear lotion as well.
Yes, as a daily treatment with 2% salicylic acid.
Okay. Any questions?
I have no more questions.
Let's take a break for afternoon coffee, and we'll get set up for treatment, and we should be finished up by that time.
Thank you.
Right, start the treatment video. What we can do is in this Zoom meeting, you can share the treatment video of the standard procedure.